We from IMA Pune welcome you all to this series of webinars starting from today, 4 days, 2 to 5 p.m. And today in the series, on the first day, we have specialists speaking on COVID. I request IMA President Dr. B.L. Deshmukh sir to say a few words before we start this webinar.
Good afternoon, everyone, faculty, delegate, and listeners. More than 2 years, we are facing COVID pandemic, and the war between COVID and we people are not yet over. To know about COVID pandemic, we have eminent speakers like Aniket Joshi, physician, professor and senior physician Dr. Kadam sir, well-known infectious diseases specialist Dr. Bharat Purandare and Dr. Amit David sir. Now I request our secretary for the further proceedings.
To introduce Dr. Aniket Joshi, he is a well-known physician in Pune attached to Sassoon General Hospital Cantonment ESIC Hospital and a number of charitable and private hospitals including ONP, Alliance Hospital, KEMs, Sahyadri to mention a few. He has been an active member of API Pune and IMA Pune as well. It is a great pleasure that he's worked extensively in COVID-19 in various ICUs and has a tremendous experience in this subject. So we, on behalf of IMA Pune, we welcome Dr. Aniket Joshi to deliver the talk. Welcome, sir.
Correct.
Yes.
Good afternoon, everybody. I first of all thank IMA Pune for inviting me to give this talk. As you know, we have all been affected by the COVID in the past 2 years, and it has been a difficult period for all of us because COVID being a new disease and it being new to the entire world, it was not that easy to cope up with such a high morbidity and mortality disease, which was not having any history in the past. Still, with all cooperation, literature which poured from the entire world, and with the zeal of all the treating physicians who work day and night to save as many COVID patients as possible, we have been able to reach to this level. Of course, government has been all governments have been very proactive in all of this activity. Vaccination programs which were run by the government have been extremely vigilant and extremely successful. And we have gone from being totally unaware of the disease to being at least partially or almost now we feel that we are in at least being able to treat the patients with evidence-based literature or evidence-based text. So the task given to me today is to explain the differences between the second wave of COVID and third wave of COVID. Now, second wave of COVID, as you know, it began in mid-February 2021. It peaked in late April and early May, and it ended by June end and early July. In the number of cases as compared to the first wave were very high. These cases required the variant at that time predominantly was Delta, and because of its high morbidity and high longer duration of illness, like it used to last for at least 4 to 5 weeks, and recovery of the patients was being monitored all throughout. So we had around 2 lakh cases in PMC alone, and out of which there were 4,500 fatalities. Rest all were rest all did well. Now, third wave, it began in January 2022. It is still ongoing. There are around 2 lakh documented cases till now. That is only in 1 month. By 1st of January or end of December, it started. But the number of cases are pretty high as compared to the second wave, because second wave lasted for quite some time. But in the first month itself, we have got documented 2 lakh cases. We still are not aware about the people who are undocumented or who are not testing at all, or who are testing at home and not reporting to the portal. So we are expecting much more than this, which is presently being documented. But the good part is that the fatalities are quite less as compared to the earlier wave. The fatalities are definitely less. The morbidity is definitely less. And the reasons for this, which is being what is the fact, is that either the Omicron variant, as has been seen all around the world, is less virulent, or the vaccination which has been taken place since January 2021 is definitely showing its effect. So this is the difference on a gross level between the second wave and the third wave. Now, when you think from pathophysiological point of view, the second wave was predominantly Delta. Omicron was not identified by that at that time. Omicron variant was identified in late November. 20th November was the time when it was first declared as variant of concern. And in 1 month, it was identified, as all of you know, in South Africa. And in 1 month, it reached India. Around end of December, we started getting a rise in the number of cases. We had gone as low as 50. It did not go to zero, but in PMC at least it had gone as low as 50. And thereafter, it started rising. The doubling time kept on reducing, and we got a peak of cases during the first wave of January itself. So in the initial 1 week, it was thought that Delta is going to be the predominant variant in at least 50% of cases, and 50% are going to be Omicron. But as the disease progressed and as we started getting patients, it was predominantly found out that the S gene deletion, which is one of the findings of or confirmatory of Omicron variant, was found in almost everybody. So as we kept on gathering data by genetic sequencing, we found out that gradually Delta has practically come down to 3%, and 95 to 96% of cases have now different variants in the Omicron. So grossly it is Omicron. So further talk is going to be difference between the Omicron variant and Delta variant. So clinically, if you see that history-wise, Omicron variant, the patients had a very short window period, that after exposure, they used to get positive in around 1 to 3 days, as opposed to a period of 5 to 6 days to 7 days, sometimes 10 days in the Delta variant. The presentation in many cases was quite acute. Like patient used to get a very high-grade fever, severe headache, then precipitated vomiting, and patient used to land up in the hospital or the clinics with a very high level of symptoms. And as opposed to that, in Delta, we used to get a subacute presentation. A patient used to say, I am not getting sense of taste, or I am not getting sense of smell, which was a predominant feature in Delta or the earlier variants also. And then we used to suspect that the patient had COVID infection. We used to do the RT-PCR, then it used to come as positive, and then we used to start treatment. As opposed to that as opposed to the Delta variant, Omicron variant, the presentation was quite acute. The awareness was very high, and therefore patients are now coming mainly with positive reports on LFD or lateral flow tests already. Fever is very high in Omicron in majority of cases, but you may get no or very less fever also. running nose is a predominant feature. Running nose was less in Delta, but running nose is a very high grade, highly probable symptom in Omicron. No loss of taste, no loss of smell is seen in Omicron. In Delta, there was a significant proportion of patients who are having loss of taste and loss of smell. Diarrhea was a common presentation in both. So in Omicron, fatigue, weakness, and high-grade fever are predominant features. And in Delta, it was mainly related to subacute presentation. Then on investigations, we found out that leukopenia or normal WBC count was seen in Omicron, and in Delta it was mainly leukocytosis and thrombocytosis. There is no lymphopenia seen in Omicron variant cases, whereas in Delta we see lymphopenia with high NLR ratio. In fact, that was one of the diagnostic of COVID. In Omicron variant, we are seeing normal NLR ratios or very less reduction in lymphocytes. D-dimer, CRP, ferritin, all of these inflammatory markers were found to be very high in the early stages of Delta infection. And here there is very marginal rise of D-dimer and in marginal rise in D-dimer in Omicron variant, though CRP is definitely seen, but not to as high level as it was seen in Delta variant. The CRP was definitely risen in, it used to rise in Omicron variant, but sometimes in 2 figures, but in Delta variant, we used to get a CRP of 3 figures, sometimes almost close to 300, 400. That was also seen in Delta variant. Then Hygiene deletion is seen in RT-PCR in Omicron variant, whereas Hygiene is present in RT-PCR reports of Delta variant. Then there is normal SpO2 and normal chest X-ray. And here the SpO2 is to be low or it is to reduce after 6-minute walk test. Then on chest X-ray, we used to see in Delta, there was peripheral shadows more at basis and starting at the peripheries. And when we used to do a CT scan of such cases, when the clinical presentation was there or clinical indication was there, we used to see ground glass opacities on CT scan. And here the ground glass opacities are not seen that commonly. We used to get on ECG tachybrady arrhythmias, and atrial fibrillation was very common in the second wave with the Delta variant. Here the ECG is practically normal, or the earlier abnormalities on the ECGs are continued as it is. What we are seeing is worsening of RFTs are also there in Omicron variant. So whatever the patient is having a diabetic nephropathy or the worsening of earlier nephropathy is seen predominantly in Delta, it used to occur, but in the later or third or fourth stage of the disease. From the treatment point of view, the Omicron variant, the symptom, just a minute. Omicron variant, we are seeing that the symptoms, they practically come down within the first 3 or 4 days of initiation of symptoms. Like most of the patients, they report for high-grade fever for the first day, and after 2-3 days, like they get treated with paracetamol and any other antibiotics. After 2-3 days with good rest and plenty of fluids and good diet, they are practically becoming asymptomatic with normal lab reports, and their recovery is very fast. So it is sort of a self-limiting disease, and as compared to Delta, which in which the disease duration was almost 1 month. In the initial 1 week, we used to get symptoms. In the next week, we used to get hypoxia. In the third week, we used to get immune suppression. And in the fourth week, the patient used to either recover or used to get secondary complications like gram-negative sepsis or other common problems. Then response to antivirals is good in both variants. The antiviral treatment is effective in Omicron as well as Delta, but the need for antiviral treatment is very, very less in Omicron variant is in this wave. It was very high in the earlier wave because the symptoms used to be persistent. Patient used to get persistent tachycardia, persistent high-grade fever, then significant worsening of the ground glass opacities. Patient used to need oxygen therapy. Patient used to need antiviral therapy. Patient sometimes needed oxygen, HFNC, non-invasive ventilator, invasive ventilator. Immunomodulatory therapy was also seen like tocilizumab, itolizumab, baricitinib. All of these immunomodulator drugs were seen in used in the second wave, which is hardly used in the third wave. I mean, it is not that it is not being used. The proportion is very less as the lungs are being spared. So predominantly grossly, we can say that in Omicron variant, it is affecting the nose, the throat, and generalized body ache and generalized fatigue. But in Delta, it does spare the lungs. But in Delta, the initial symptoms were very less, but it did affect the lungs in a very very high extent, and it was almost like if we don't treat the patient in the initial 1 week, it was invariably thought that the conversion of patients or patients who presented late, they presented directly with hypoxia and very high probability of ARDS. Also, the treatment of the probability of complications like mucormycosis and other fungal infections and viral infections was very high in Delta variant, which is very less seen in in Omicron. So mortality, but one part is that whether this is the effect of vaccine or whether this is the effect of Omicron, that we are not able to ascertain as of now. Mortality in unvaccinated and high comorbid condition with Omicron is also very significant, though we have to yet to get the final figure because we are just 1 month into the third wave. We'll get the figures in the next 2-3 months to come. But mortality in unvaccinated, as has been reported by various ICUs, whatever 50-54 ventilated cases are there, almost 80 to 90% of those cases are either unvaccinated or partially vaccinated. So whether this is effect of vaccine program or whether this is effect of Omicron's less virulence, we will come to know in the subsequent months. So ultimately, what we are expecting is now that the number of cases are on the decline, we are expecting that all of these cases, most of them are going to be less morbid. The mortality is also less in this wave. And let's hope that this trend continues and we will get out of this, at least out of this third wave as early as possible. It is predicted that we will get the out of this third wave by mid-March. So the trend definitely shows that we'll get out of it. Then there is a little bit of shift of slides, I think so. So in Omicron, we used to get a lot. We have got a lot of headache, altered behavior, sore throat, change of voice, cough with expectoration, body ache, fatigue, and the disease is self-limiting and recoveries in 1 or 3 days. In Delta, we got fever, shortness of breath, fatigue, hypoxia, and there was definitely a progressive worsening if the disease was not picked up in time and not treated properly. Complications of Omicron, which we are seeing, are encephalopathy, nephropathy. A lot of patients, they come with headache, altered behavior, and they improve with a short course of steroids within a matter of 3 to 5 days. Then bronchitis is very common. In Delta variant, we used to get totally dry airways and during intubation also, but it used to be highly inflamed and very, very tachypneic patients. But in Omicron, now we are seeing a lot of phlegm coming up and there is a significant bronchitis. There are incidents and reports of co-infections with other viral infections such as herpes, which is rare but seen with Omicron. And in Delta, we saw a lot of secondary bacterial and fungal viral infections. So again, outcomes, there is a complete recovery in 3 to 4 days by Omicron. In 7 to 10 days, the person is actually back to work. In Delta in second wave in the Delta variant, recovery was in the mild variant. In mild cases of Delta, the recovery is complete in 7 days. In moderate cases, they took approximately 3 to 4 weeks to settle down. In the cases where the disease was moderate, as seen in our second wave, and severe, the recovery was very prolonged. It used to take couple of months or 3 months when the CT score used to be very high and the patient had multi-organ involvement. In some of the cases, they were not so lucky and they got treatment, but despite treatment, they could not make it. So the mortality is definitely higher in the second wave and less in the third wave. And the quarantine period initially was 2 weeks, and now it has come down to 7 days. Now we are getting reports that we are in the phase where certain countries are not asking for compulsory mask behavior also. So in short, if you see that all of these differences are showing that it is either a less virulent virus or it is a effect of completed vaccination as is seen. Therefore, I feel that we should give it more time. We should study. API Pune branch has come up with a good initiative. We are collecting the the observations of our cases, and shortly we'll be coming out with our own data saying that how effective and how these patients were treated and how they recovered in as less time as possible. So I will stop here. If there are any questions, I will be ready to answer. Some there is a question by Dr. Pratibha. Yeah. Some unvaccinated never became COVID positive. What is the reason? So reason for this is they must be following good COVID appropriate behavior. They must be following good hand hygiene, and because of that they got protected from this. Because mask and COVID appropriate behavior are going to stay for quite some time in our lives for next few years at least. So that might be the reason. If there are any more questions, I will be ready to answer. So we'll wait for a couple of minutes.
Yeah. Any participants have any more questions related to the present wave? They are most welcome to ask the questions in the chat box or in the question and answers box.
So overall, what we feel is we have to be vigilant. I think there are questions. One is in chat box.
Genetic link
to reason for serum ferritin, genetic link to severe COVID. Sorry, if you can please elaborate this question, I'll be able to answer it in a better way. There are genetic links to severe COVID. From the genetic link from the human perspective are being studied, and we'll have to wait to get those answers. Till now, there has been no particular cross evidence saying that this particular part of the genome is responsible or this mutation is responsible, etc. So, yeah, reason for serum ferritin and B12 raised after Omicron positive patient. B12 is not connected. It is probably that B12 is raised because we are prescribing a lot of B12 to these patients. And ferritin is a part of inflammatory process. So ferritin is bound to rise in any acute inflammation. So next question is routine vaccination after how many months to be given if COVID positive? Because majority kids are positive. Now in children, if the kids are positive, there are presently no guidelines of vaccination for children below 15 years. For 15 to 18, if they are positive, then we have to wait for 3 months as we wait in adults also. And I think that will be helpful. For children, we are waiting for the vaccine for less than 12 years, less than 15 years. It will just around the corner. And if we get that vaccine, we'll have to start vaccinating. The same rule will apply. We'll have to wait for 3 months after the recovery. Anonymous attendee is asking whether is Omicron sparing the elderly? No, it is not. It is not sparing the elderly. It is affecting the elderly, and in fact, they are getting more morbidity. Routine vaccination, yes, routine vaccination is not presently for less than 15 years. I mean, routine vaccination is other than COVID, you are asking. Any vaccine, you have to wait for 3 months after the COVID has, after recovery from COVID. Yeah, just a minute. Sir, there is some mix of cases. Since we do not have access to genomic studies, correct, we are proceeding only hypothetically. Now, genetic study is not available to genomic study, or genetic study is not available to us also. We are also proceeding based on the clinical picture. Therefore, the identification of clinical picture is very, very important. This, in this way, we are getting only nose COVID, throat COVID, and generalized inflammatory changes. The lungs are getting spared. And if there is a lung involvement, we have to treat with IV antiviral drugs and other protocol, which is all well known to you. Role of antibodies is the only challenge, is whether we should be giving antibody therapy in cases where we are suspecting Delta. So there are a few labs which are giving us report in 24 hours. For example, there is GenePath, which gives us a confirmed report whether this variant is Delta or Omicron in 24 hours. So you can make use of that facility and give antibody therapy if indicated. But overall, it doesn't seem so. And most of these patients are getting well within the first 3 days. So they are not requiring oral antivirals also. Role of COVID, role of chloroquine in third wave in the viral phase of disease. Presently, I am not using any of these drugs for treating any acute illnesses, because they are it is a self-limiting disease. So chloroquine presently is not being used. Siddhesha. Yeah. With very close contact of COVID patients at home, the relatives got symptoms, malaise, but RT-PCR came negative twice. Is booster vaccine advised here, or should the relative go? Yes, you can go ahead with IgM antibodies to see whether the person has infected or not, and there is no harm in. If the patient is symptomatic, you have to assume that the virus is presently Omicron variant of COVID. So it's better to wait for 3 months before you take the booster. Now there is one more query. I have a patient who transmitted COVID infection to an elderly patient after 18 days of quarantine. An elderly patient died in that. Physician says 20 days of should have been followed. Well, the government is asking for 7 days, and community transfer has been accepted. as a mode of transfer. So it is very difficult to ascertain whether the elderly person had got infected because of that patient or no. So this claim has to be discussed on a one-to-one basis. Please, can there be a mix of Omicron and Delta in a patient not practically seen? It was early hypothesized that Omicron and Delta can coexist in patients, but practically it is now not seen in any of the patients. There is one more query. Advantage of booster dose, even though two doses can last immune response for 5 to 10 years, depending on present individual immunity, please explain. So about the booster dose, there is a lot of research going on, and in that we are finding out the waning of the duration of waning of immunity, how much it is. After taking a particular dose of COVID vaccine, it is presently hypothesized that it is going to last for 6 to 9 months. And therefore, the duration of booster since the last dose was kept at 9 months. But still research is ongoing. As you all are aware that this disease is just 2 years old, and for giving any comment about any vaccine, we require at least 5 years of observation. So we have to follow the government-based guidelines for that. Why COVID spare children? Because children have got a large number of lymphocytes, and their thymus and their upper respiratory, lymph nodes in the upper respiratory are very active, and probably that is the reason. And this was the hypothesis in the earlier days, but now we are seeing a lot of children, and Omicron is evading that immunity also. Role of antivirals in third wave. As I have told that we are observing patients for 2 to 3 days. If they are getting asymptomatic, then we are not using any antivirals. But if the symptoms persist, 7 types of symptoms like persistent fever, tachycardia, then if there is worsening of saturation, or if the patient starts becoming hypoxic, if there is any other organ involvement, then we are using antivirals in this particular wave. 3-month-old baby's parent have got COVID positive. Baby's regular 14-week vaccine as per schedule of no. But if the baby, you should test the baby's RT-PCR and then decide. As Omicron is mild, why do RT-PCR? It is presently necessary to diagnose by RT-PCR, and we'll have to wait for 1 more month to say that RT-PCR is not necessary or necessary. What are the chances of getting reinfection with the same COVID variant? Very less, but not zero. Should all patients of URTI undergo RT-PCR? Presently, yes. Question? Okay, so I have been able to answer almost all of them, and if there are any further questions, you can keep on posting. I'll answer them on a text base. Thank you all for your time, and I hope I was able to throw light on the topic which was given to me. I once again thank IMA for giving me this opportunity to speak on this very dear topic on a very elaborate and big conference. Thank you very much.
On behalf of IMA Pune, I would like to thank Dr. Aniket Joshi, sir. We have almost 250 participants with us, and sir has answered all the major and minor differences between the Omicron and Delta variants, and all the questions have been answered. I request our president, Dr. B.L. Deshmukh sir, to felicitate Dr. Aniket Joshi sir with bouquet and Uparana.
Thank you for you.
Thank you, sir. Thank you very much. Thank you.
Chandra, like that.
Thank you, sir. Thank you. Next in this sequence, we have Dr. Dilip Kadam sir with us, who would be speaking on home isolation guidelines in the third wave. We all know Dr. Dilip Kadam sir is a popular figure in Pune. He has been the chairman of the COVID-19 task force. He is a professor in Navale Medical College and also an professor emeritus in BJMC and Sassoon General Hospital. Has a vast experience of 36 years of teaching and training students. 76 research papers to his credit. He's received an Master Teacher Award from the Association of Physicians of India, API. And he's a guide, investigator, chairman, and member of various medical committees in India, Maharashtra, and Pune. We welcome Dr. D.B. Kadam sir for his lecture. Piyush, can you add Dr. Kadam sir to panelists?
Yes, sir. Sure. Dr. Kadam and
I think he is joined in the with the other link.
Dr. Kadam and who, sir?
Pardon me,
Dr. Kadam and who?
Dr. Dilip Kadam sir.
I added him and I can't see him.
Sir has joined.
Yeah, he's here. He needs to connect through audio. He needs to connect his audio. Yeah, he's on.
We welcome Dr. D.B. Kadam sir. Sir, could you please unmute yourself?
Hello.
Good afternoon, sir.
Good afternoon. I'm just trying to share my slides so that I can start. Just a minute.
We also have with us Dr. Sunil Ingre sir, Secretary IMA Pune, and Dr. Alka Shirsagar Madam, Secretary IMA Pune with us.
Okay. Can you see my slides now?
Not yet, sir.
Not yet.
We are seeing the folder.
With my, I'm seeing my slides. I think this is slide issue.
Click on the. Piyush, can you guide, help, sir?
Stop karo, start.
Or otherwise, I will stop and again rejoin. Will that be okay?
Yes, sir.
Because I'm seeing the slides, but those are not getting projected with your.
So you can exit and share screen the button.
I will stop share and share again. Screen. Are the slides visible now?
Yes, sir.
Yes, sir.
Clear.
Right. So good afternoon, all of you, and the participants. Obviously, now this particular topic is related to our the COVID pandemic, which is ongoing. I'm thankful today IMA for giving me chance to talk to you all and my few ideas about it. And, now my topic, which one is home isolation, and what are the things we should look for in home isolation. Now, if you look at this slide, we have all these variants to start with alpha, then beta. Fortunately, beta didn't come to India with that particular thing, and it was more in South Africa per se. And then we had a delta, and now Omicron is replacing delta pretty well. As far as today's statistics is concerned, it's only 3% Delta and 97% Omicron. What is being reported by Noble Hospital. So Omicron is practically replaced the Delta variant per se. Has that changed any of the home isolation guidelines, and how the things have changed? We will just see in a while. Now, Aniket has very well dealt with the differences between Delta and Omicron. I don't know whether this slide was discussed or not, because I joined 5 minutes late because of the internet issue. But I will just go through this to say why today the role of general practitioners is more important than hospitals and the indoor facilities. If you look at the differences, this has been from South Africa. The patient median age was older in patients with Delta virus, while it is younger in Omicron. So if you look at age affection, all the age groups are equally affected in Omicron, while Delta was affecting older age group more prominently. So even if you take 0 to 10, 10 to 20, or if you take 40 to 50, you will see around 10 to 12% patients in each of these age group. But as Aniket has delineated, the disease course is mild in younger, and it is only problematic in patients with comorbidity. Acute respiratory symptoms are present mainly in Delta, 91% versus Omicron, 31. So what does this tell us? That even if acute respiratory symptoms may not be there, we must keep Omicron at the back of our mind. What is the most important symptom in that? The loose motions and vomiting, and constipation at some time. So this we have to remember, that even if patient comes with loose motions and fever, so instead of diagnosing enteric fever, we should think of the Omicron variant first. Duration of hospitalization, Omicron doesn't need hospitalization in most of the patients. We'll see in a little while, but if they require hospitalization, the respiratory complications they are taken care very rapidly. So it is not needed to stay for a longer duration in the hospital. Oxygen requirement also is less likely to be needed in Omicron than our figures are pretty different than what the figures which we are seeing. If you look at it in Pune, the Pune Municipal Corporation publishes reports every day, and what it has shown, the admission is required only for 3.1% persons, and ICU requirement and ventilator requirement is only in 0.15%. So the admission facility, hospitalization, oxygen requirement is very, very less in patients with Omicron. As Aniket had rightly said, whether this is vaccination effect or the virus itself is mild is yet to be evaluated. So ICU admissions are less, ventilatory supports are meager, and mortality is also much less. So when they compare the same thing which occurred in second wave and the third wave, in second wave when there were around 1 lakh cases, and in the third wave when there was the 90,000 cases, the deaths in the second wave almost 140 per day, while it was only 8 per day in third wave. So deaths are also less. So that's how the Omicron is different than the, just a minute. Zoom meeting मध्ये lecture देतो लगेच करतो. So there is a difference between this, and we need to keep this in mind. So what does this indicate? If you look today's PMC the data, 95% patients are in home isolation. Only 5%, that too again in Pune 3.1%, where patients are in hospital. So that speaks of why home isolation management has become most important today with Omicron than that of Delta even. What happened to slides? Sorry, slides are not moving. I'll just take some help.
We can see your slides, sir.
Slides moving. Just a minute. Yes. So this was the thing which was published by AIMS in second wave, that if you have dry cough and sneeze, it is likely to be air pollution. Cough, mucus, sneeze, runny nose, it is likely to be common cold. Cough, mucus, sneeze, runny nose, body ache, weakness, mild fever, it is likely to be influenza. And dry cough, sneeze, body ache, weakness, high grade fever, difficulty in breathing, it is COVID. But this was true only for the second wave. In third wave, we are seeing lot of sneezes, lot of rhinorrhea, body ache is worst, fever is pretty high. Okay, so dry cough has been replaced, but there is no difficulty in breathing. So we need to remember when we see a patient in OPD, what to diagnose and how to diagnose COVID in today's scenario. In today's scenario, anybody coming with fever, body ache, severe myalgia, and upper respiratory tract the symptoms or loose motion should be evaluated for corona straight away. Now, these are the basic of guidelines which have been published by Government of India, and this is recently published on 5th January, and they will speak out how we should manage patient at the home isolation. These revised guidelines tell you that the patients are asymptomatic and otherwise asymptomatic or mild symptomatic should be home isolated. But now this is not true. It's a partially true because we have stopped testing asymptomatic patients. The contact tracing is now taken out by ICMR in testing in the field. So if the patient has contacts and only when contact becomes symptomatic, we need to test them, not otherwise. So these guidelines will be applicable for mildly symptomatic to moderately symptomatic persons who have the COVID positive status, either by rapid antigen or by RT-PCR or by CBNet. These are the three tests which we are using most commonly. The secondly, patients are doing self-testing. Self-testing is rampant, but the patient do not report it. So that's why there is a falsely decreased number of patients than what we are seeing presently everywhere. So we should first encourage our patients that when you do your own self-testing, please report it, because the statistics which I heard was almost 20 lakh odd the kits have been sold all over the country, and not even 1% have been reported back about what was the report of that particular testing. Now, who are eligible for home isolation? So we have to say that clinically assigned mild or asymptomatic. As we have said, asymptomatic we are not testing. So what do you mean by mild symptomatic? Mild symptomatic, so whenever you look at the patient has fever, patient has body ache, patient has sneezes, and patient has throat pain. So whom to call as mild? So all the patients will have fever of around 99 to 102 degree Fahrenheit, and which will persist for 2 to 3 days. So if the patient's fever is 102, does it become serious? The answer is no. So we can use paracetamol and see the response of the paracetamol for the fever. And if the fever settles down with paracetamol alone, there is no need for admission. So what today we see, that patient comes, he's frightened, the temperature is 102 and has shivering. So they insist on us that please get us admitted. But this should not be encouraged. You tell the patient that wait for 2 days. Within 2 days, your fever is going to resolve. So you stay in home isolation. So that the assurance we need to give to the patient when they come with the high fever. Then once we decide that this patient should be home isolated, the first the thing is to ascertain that he has space for self isolation or quarantine in the family. So ideally, what do we need? We need a separate bedroom with separate washroom, so that he can take care of himself at home in his room and need not come out for daily requirement. If it is a common toilet or washroom, then these patients are likely to mix with each other. So then home isolation cannot be advised. But if you look to today's scenario, if one person is positive, practically rest all family becomes positive within 2 to 3 days, and all of them turn out to be either rapid antigen positive or RT-PCR positive. In that case, we need to rethink this particular necessity, and ideally, the patient should have a separate bed and separate washroom. Third important thing needed is caregiver. So why the caregiver is needed? If the patient needs any drugs, patient needs any investigations to be done, to call a lab person to get the lab done, or the patient needs any other help, there has to be a caretaker to serving food for him, giving his daily requirement. So caretaker must be present and should be available on 24/7 basis. And that caretaker should understand how the home isolation patient should be managed. And ideally, the caregiver should not have comorbidity, and caregiver should have completed his 2 doses of COVID vaccination, so that he is immunized. And even if he contracts the disease, it would be mild and will not lead to any respiratory failure. And there should be a communication link between caregiver and medical officer, so that he informs the medical fraternity as and when he notices any danger signal or red flag sign, which we will be seeing soon. So what should we advise home isolation in few of these conditions, like age more than 60, comorbidity, immunocompromised status. The comorbidities which are important are hypertension, diabetes, heart disease, COPD, liver, kidney disease, cerebrovascular accidents. So in these patients, what we have to first think of is, even if age is more than 60 years, patient doesn't have any comorbidity, he can be advised home isolation. Okay, if the patient has comorbidity, if the patient has hypertension but blood pressure is well controlled, if the patient has diabetes but HbA1c is in the range of 5.5 to 7, if the patient has heart disease but doesn't have cardiac failure, he is comfortable and he is in NYHA grade 1 dyspnea, then we can advise him the home isolation. Patient has COPD. So which patients do bad? The one with the COPD and second with the kidney disease. So these two sets, they do bad. And as Aniket has just told you, the renal function abnormalities are seen pretty often with these patients. Similarly, if in the transaminitis is more common in the Omicron patients. So patients with COPD, patients with liver cirrhosis, patients with CKD should be advised hospitalization instead of home isolation. Cerebrovascular accident patients, if they are bedridden, obviously they would require hospitalization. If they are ambulatory recovered cerebrovascular accident, then the patient can be advised the home isolation. So proper evaluation is needed, and when we evaluate it, we need to evaluate comorbidity severity, and whether patient has comorbidity associated complications. So if the patient has comorbidity associated complications, then it is better that the patient should be the advised hospitalization. So for example, if the blood pressure is more than 150 by 100, if the HbA1c is more than 7.5, if the patient has heart disease with the pedal edema, raised GVP, or tachypnea due to heart failure per se, then this patient should be encouraged for hospitalization than for the home isolation. So that's how we will take a call for patients with comorbidity and age more than 60 years. What about immunocompromised status? So immunocompromised status, as far as patients with the PLHIVs are concerned, the corona per se hasn't behaved differently in the PLHIVs, and the morbidity and mortality was at par with the general population. There was seen an increased risk of death in these patients if the patient is on antiretroviral therapy and if his CD4 count is more than 250. So if that is so, then patient can be home isolated. If the patient is of malignancy and on anti-malignant drugs, and if he has normal hemoglobin, there is no bicyto or tricytopenia, then again we can take a call, and if all other systems are okay, then we can still go ahead and ask him to have home isolation. So as far as patient comorbidity and immunocompromised status is concerned, we have to take into consideration the patient's general health, patient's ability to cope up with the disease, patient's ability to observe all the precautions during home isolation, and then only advise him to go for home isolation or to go for hospitalization. What are the instruction to the patient? In the instruction to the patient, one must isolate himself from others. So obviously, what we would try to do is to avoid passing on infection to the others. Ideally, the distance between the two persons should be around 6 feet. You should stay in identified room, away from others. And because of increased infectiousness of the Omicron, even if you sit across and talk to the person over a period of 10 minutes, you are likely to transmit the disease if you both of you are not wearing a mask. If you are wearing a mask and both of them are wearing a N95 mask, then the transmission possibility becomes much more less. So to avoid transmission, the social distancing is a must, and that facility should be there in that particular home. Okay, and elderly persons and comorbid persons are likely to pick up this disease early and likely to become bad. Hence, the person who is in isolation should should not be in contact with elderly persons and comorbid persons, definitely. And by elderly, we mean more than 70 years of age, because 60 to 70, there is some threefold increase, but after 70, there is almost sevenfold increase in complication rate. Next is the necessities. It should be well ventilated room with cross ventilation. So there should be windows against each other. Ideally, what we say is 7 air exchanges in the room should be present to take care of better air quality. So well ventilated room is needed so that the virus particles which are there in that particular atmosphere should not get concentrated and should go across to the other rooms for infecting others. Use triple layer medical masks. So surgical masks are available in two varieties, 2-ply and 3-ply. So if you use 2 3-ply surgical masks, then chances of transmission becomes practically the least and minimal, and it is as effective as your N95 mask for the transmission purpose. So the triple layer mask should be used, and if the person is infected, he should use two triple layer masks, the surgical mask, to avoid infection to the others. What care we should take with the mask? So this mask, if becomes wet, then its efficiency goes down. So it's ideal to discard the mask after 8 hours of use. And if caregiver is entering into the mask, into the room, then caregiver and patient should wear 2 3-ply surgical mask or should use N95 mask to prevent the transmission. Mask to be discarded after cutting into the pieces to prevent reuse of it, and disposal should be in a yellow paper bag indicating it's a biological waste. If you keep it for 72 hours, then all the viruses will die, and then that particular mask can be thrown out. Then he must take a rest because excess of activity will increase post-viral fatigue syndrome. So post-COVID fatigue and post-COVID POTS, that is postural orthostatic tachycardia syndrome, is seen in a lot of patients who do not take rest during the active infection. The autonomic imbalance is seen in them thereafter. So the patient should be insisted on taking the rest when especially when the patient has severe body ache, muscle ache, myalgia. The patient must take rest to prevent post-COVID complication. Dehydration due to the fever is common in them, and patient must hydrate him well. He can take lukewarm water if cold water is not palatable or producing any problems, but he should take a lot of fluids. The important symptom which these Omicron patients have is severe dysphagia. Throat pain and dysphagia persist in almost around 20% of the patient for 7 to 10 days. And the rate in the pharynx will be seen during this. And because of this dysphagia, patient tries to avoid taking fluid. So they should be encouraged to take as much as fluid because hydration is the first way to prevent the serious complications in this particular disease. So around 2.5 to 3 liters of fluid daily should be advised to them. Then next is to follow respiratory etiquettes. When the patient sneezes or patient coughs, he must cover his the nose and mouth and should not allow the droplets to spread around. So that should be taught to each and every patient. The mask is a must. The most of the time, what you see when patient tries to sneeze and cough, they will take off the mask and then do that. So which is a wrong method. So this has to be emphasized for the patient. Then next is to prevent the spread of disease is frequent hand washing. Ideal would be to use soap and water for at least 20 to 40 seconds or to use alcohol-based sanitizers. So alcohol-based sanitizers, they should be used frequently, and whenever they touch nose, mouth, or the mask, ideally they should avoid touching it, but inadvertently if they touch it, they should immediately should wash their hands with the sanitizer or with soap and water. The next point is not to share personal item, including utensils. So the food should be served for that patient in that room only. He should not be called out for taking food with all other relations. So that would spread the disease. The utensils, whichever are used, should be washed by the patient himself and then should be handed over to the caregiver. The next point is to ensure cleaning frequently touched surfaces by surface wiping with the sanitizer or with soap, detergent and water, whichever is feasible. So this will take care of viruses which are there onto the cupboard and table and other surfaces. Now then in monitoring, so monitoring has to be the first and foremost, what is most must is blood oxygen saturation. The pulse oximeters are available in place in the market, but we have to ensure the quality is good, because some of my patient has called me that my pulse ox is 81, and when they were called into the hospital and checked, the actual saturation was 98. So the quality of pulse oximeter should be really good and should be rechecked and tested. I prefer using contact the pulse oximeter, which gives a pretty good results and doesn't produce such emergencies. So local made or uncalibrated pulse oximeter should be avoided, and patient should be taught how to use it. So if the patient puts hand into the cold water, so right now is a cold season, the peripheral vascular constriction will occur, and if you check saturation with that, obviously saturation will become less. So before checking the saturation, patient should rub the hand, warm his hands, and then put into the pulse oximeter and look out for the saturation. He should monitor his daily temperature, and if the fever persists for more than 3 days, obviously it's a red flag. He should immediately contact his doctor and should get admitted. They promptly report any other deterioration. So new onset of fever, new onset of loose motions should be reported immediately. Any new symptom, the patient should immediately talk to the medical fraternity. The 6-minute walk test for all those who are less than 60 years of age, and 3-minute walk test for all those who are more than 60 years of age should be advised. And when they do walk test, at the end of walk test, again pulse oximeter should be applied. And if there is a fall in saturation by more than 3%, that gives you that this particular patient has the respiratory insufficiency, and this patient should be admitted for further investigations and further management. So this should, and they should walk in the same room, not outside. You walk in the room for 6 minutes continuously or 3 minutes continuously, depending upon their own the physical the capacity and age group, less than 60 or more than 60. In patients with COPD, if the resting in the room, the on room air saturation is less than 93%, these patients best be hospitalized rather than asking them to stay at home, because you will get frequent phone calls from them that the saturation has dropped to 90, 88, sometimes 85. So patients with COPD, the saturation they should be above 93 at least before we advise them home isolation. Then self-health monitoring chart should be maintained. And this looking for pulse pulse oximeter should be done at least 3 times in a day. Temperature should be measured at least 2 times in a day. Heart rate should be measured 3 times in a day. Saturation 3 times. And how does the patient feeling? So whether he is feeling energetic, his appetite has returned back, his body is becoming less, and whether there is any evidence of breathlessness or not. So all those things should be recorded. And if you find that there is a resting tachycardia, that the patient's pulse rate is going above 100, saturation is becoming less than 93, and the breathlessness, if the patient is feeling breathlessness, or there is a severe anorexia and patient has dizziness, then such patients should be discontinued from home isolation and should be admitted to the hospital. For caregiver, obviously he should wear mask, triple layer, double surgical mask, or N95 when he enters into the ill patient's in the room. Hand hygiene should be monitored. The frequent hand wash, with sanitizer or soap or water, with all the WHO given 12 steps. Hand wash should be taught to this particular patient, and whenever he goes inside, comes out, so he should first wash the hands and then go and mix up with other the persons in the room. Exposure to the patient's or patient's environment, they avoid direct contact with body fluids and use disposable gloves. A plastic gloves are good enough they to go inside and take care of the patient's clothing and other the things in the patient's room. The next one is the biomedical waste disposal. Effective and safe disposal of general waste is must. Used masks, gloves, tissues, swabs contaminated with body fluid of COVID-19 patients, then syringes, medicines should be treated as biomedical waste and should be disposed of in yellow bag. So that it should not give rise to infection to others and should be handed over to the waste collector separately, stating that this is biomedical waste and should go for incineration. Appropriate deep burial pits, if the waste collector is not available, then deep burial pits should be available in patient's vicinity to they take care of these biomedical waste. Now, investigations. What investigation should we advise home isolated patient to do? So the patient should undergo CPC and CRP as a baseline investigation. If your CPC shows NL ratio more than 3.5 and if the CRP is more than 50, then these are the patients who would require more close monitoring. So before asking them to have home isolation, we should look out whether they have comorbidity, and if the comorbidities are present and if they have these two parameters, then obviously we will ask them to get hospitalized. In CPC, what we have seen in Omicron is this NL ratio is not more than 3.5, rather lymphocytosis is seen and monocytosis is seen. If the monocytes are more than 10% and if the NL ratio is less than 3.5, then this is likely to be Omicron and likely to be milder in nature. So that will give you indication and you can assure patient that nothing bad is going to occur for you. So what about other D-dimer and ferritin? So D-dimer and ferritin, these are the inflammatory markers. We do it if the patient has reappearance of fever or if the patient has new symptom onset, and should be done after 5 days of the illness if needed. So if the patient's fever was there on day 1, day 2, disappeared and reappeared again on day 5, day 6, then one should go ahead and do D-dimer and ferritin. What about LFT, RFT? The transaminitis and mild increase in RFTs is seen in Omicron patients. So if the patient has transaminitis or mild increase, one should not get panic about it because this is self-limiting one and is going to settle on its own. But if the patient has underlying renal or hepatic disease, then that can make it worse. So those patients should be advised hospitalization and should not be done as a routine. If the patient remains persistent symptomatic after day 3, then we can think of doing these investigations additional, or if the patient has persistent anorexia. HRCT, present Omicron, hardly ever you need HRCT unless patient is hypoxic or patient has dyspnea, patient has tachypnea, then only HRCT would be helpful. Doing HRCT and getting score less than 5 is of no use because that would settle down on its own without any antivirals. The details of it will be talked by Dr. Amit David and Dr. Bharat Purundere later. X-ray chest is also not needed unless patient has persistent cough more than 5 days, has hypoxia, it has dyspnea, and or productive cough. In that case, X-ray chest should be warranted. So investigation should be done judicially, and not every patient should undergo all the investigations. So what treatment they should we ask for the symptomatic patient? He should promptly report for any deterioration, continue medication for comorbidities. In this comorbidity, we must remember diabetes. We have seen diabetes becoming worse even in absence of steroids. So sugar monitoring should be more intense if the patient becomes corona positive, and sugars more than 250 postprandial are seen in these patients even without steroids. So that must be remembered. And if the patient has high sugars, then his appropriate anti-diabetic medication should be increased. If he's on insulin, dose needs to be increased for that particular insulin. As far as blood pressure is concerned, these patients, they take combiflam, they take diclofenac, and they have hypertension as the result of it. So this should be, they told to the patient that you take only paracetamol. If you are going to take combiflam or any other, then obviously blood pressure monitoring would be required, and antihypertensive drugs will need to be stepped up. Teleconsultation by using mobile should be available for the patient to talk to the doctor. Symptomatic management of fever by paracetamol, running nose by antihistaminic, and cough by antitussive like dextromethorphan or codeine. They should be advised to these particular patients. And montelukast with antihistaminic combination gives a good symptomatic relief for them. Now, warm water gargles, but when we say warm water gargles, the people try to take literally boiling water, so that will burn the throat. So we should say that it should be lukewarm water and not the boiling water, because this particular virus stays alive even at 60-degree temperature, and no one can gargle with 60-degree the hot water. Steam inhalation, again, the same thing should be applicable over here. The people take stimulation for hours together. So it is not needed. The 5 to 7 minutes of stimulation is good enough to moisturize this put up and to have good expectoration. And consult the treating doctor if fever is not controlled, if the body is persistent, if there is a dyspnea or breathlessness, then you should immediately talk to your physician. What is most important? Misinformation and having odd ideas regarding, as we have just said, regarding gargle, regarding your stimulation, that will help patients more. Do not self-medicate. So by reading onto the WhatsApp, the people are using a lot of alternative medicines, also using the unproven medicines like ivermectin, the hydroxychloroquine, azithromycin. All those should be stopped now. The lot of use of vitamin C and zinc has led to hyperuricemia. And if you have noticed in Omicron patients, you are getting increased number of patients with hyperuricemia. So these things should be avoided. Steroids should not be used unless there is hypoxia. That's the dictum. So if you use steroids more, the diabetes will become worse and mucormycosis will be the result of it. And generic sharing. So so one person in the family has COVID, if the doctor gives him the prescription, another person becomes positive, he follows same drugs. So this should be avoided because the comorbidities are different, the risk factors are different. So each one would have a different prescription depending upon comorbidity status and other clinical presentations. Falling such oxygen saturation or onset of breathlessness should lead to termination of home isolation immediately and hospitalization. So when to seek medical attention, unresolved high-grade fever for more than 3 days. Over there, we try to give antivirals in addition. Severe fatigue, myalgia, patient unable to walk, right up to washroom even. Then yes, the patient should be hospitalized. Difficulty in breathing, if the patient becomes breathless, has resting tachypnea, obviously patient should get admitted. Drop in oxygenation less than 93 or 3% drop after 6 or 3-minute walk test, then this patient needs admission. Respiratory rate more than 24 per minute will need hospitalization. Persistent chest discomfort or chest tightness would indicate bronchospasm, and this needs bronchodilator by inhalation route by nebulizer should be admitted. Mental confusion or inability to arouse or drowsiness, if the patient becomes disoriented and doesn't answer you well or when you give a phone call or when he calls you, that would indicate a presence of hypoxia. So in that case, the patient needs termination of home isolation. So when should we discontinue the home isolation? 7 days have passed from the testing positive and patient is asymptomatic. No fever for 3 successive days, body ache and other things have resolved. A mild dry cough can be allowed. Mild dry cough will persist in Omicron patients for a period of 7 to 10 days. Similarly, mild dysphagia can persist, but that should not be taken as symptomatic patient. So those patients, you can definitely terminate home isolation. But give a clear-cut idea that patient has to wear mask for next 7 days, even the home isolation is terminated. Retesting is not needed for mild and moderate. Those only on ventilator should go for retesting. So home isolation patient do not need retesting. If they do retest, most of them will turn out to be positive at the end of 7 days. But obviously, there is no viral replication. Even dead virus will give you RT-PCR positivity. So there is no need for retesting. Risk retesting should not be emphasized. Asymptomatic patients, no need to undergo COVID test, monitor health during home quarantine, and only if they become symptomatic, then do COVID test. So those are the instructions which I wanted to pass on to all of you regarding home isolation. So if there are any questions, any queries, we can definitely sort it out. Hello.
So good afternoon. We have some questions here in the chat box.
Yeah, sure.
There's a question from Dr. Vinita Nalaude. When increasing the fluid intake, should plain water be consumed or small amount of salt to be added?
Right. So basically, as far as fluid intake is concerned, a lot of fluid loss is because of fever and dehydration due to fever. And sweat contains very less sodium in the sweat. So routine addition of salt will not be needed. Routine addition of salt will not be needed. If the patient has loose motions, then yes, electrolyte solution would be better. While giving this particular advice, we must also look at his cardiac status. If the patient has heart disease, had history of decompensation in the past, then obviously adding salt will add to the problems. So if the patient doesn't have loose motions, plain water is good enough. If the patient has loose motions, electrolyte solution or sodium should be added. And when we add it, the water intake, we should keep in mind the patient cardiac status and renal status. How long before symptoms person is infectious to the others? So basically what we have the studies have shown that if you contact with the person today, then it takes around 5 days for person to develop the symptoms, and 3 days prior to that the patient can be infective to the others. So after contact, 48 hours are required for colonization, and thereafter person can become infective, and this occurs in almost 85% of the patients. Very few will have a long incubation period more than 10 days. Any other?
There are no more questions asked in the chat box.
Yes.
On behalf of IMA Pune, we thank you, sir, for taking out your valuable time and enlightening us about the home isolation guidelines for this third wave. On behalf of IMA Pune, we would like to felicitate you I request our President, Dr. B.L. Deshmukh, sir, to felicitate you with the bouquet.
So this is e-bouquet for you.
Thank you. Thank you. Namaste, sir.
With this, we thank the participants also, those who have joined in huge numbers. We have crossed 250 participants, and with this, we move on to the third lecture. Today, we have with us Dr. Bharat Purandare, who would be speaking on lung involvement in COVID and its sequelae. As you must have heard him earlier, Dr. Bharat Purandare is an infectious disease physician in Pune attached to Dinath Mangeshkar Hospital and has private practice. He has done his MBBS and MD from BJ Medical College and infectious disease fellowship at Hinduja Hospital in Mumbai. He runs a postdoctoral infectious disease fellowship program at Bharati Hospital in Pune, and he has various publications and has actively worked in the fields of TB, HIV, transplant infections, and travel medicine. With this, I hand over the proceedings to Dr. Bharat Purandare. Welcome, sir.
Thank you. Am I audible?
Yes, yes.
Yes, you are.
And my screen is visible?
Yes.
Okay. Okay, thank you. At the outset, let me thank IMA Pune for inviting me to give this talk, and I'm thankful to the organizers of this webinar, the dignitaries of IMA Pune, Dr. B.L. Deshmukh sir and Dr. Kedar Patil sir. I thank you from the bottom of my heart for giving me this opportunity to speak in front of our beautiful audience of doctors who are all our dear colleagues. And today I'm given this topic of lung involvement in COVID-19 and its sequelae. And I'm going to talk very briefly about this topic, but in itself is a very huge topic. But let me sum it up in a few slides. And after an excellent talk of Dr. Dilip Kadam sir, who gave us all practical advice about how to manage a COVID-19 case, this is the next lecture in this sequence. So basically, I'm a consultant in infectious disease. I work in Dinath Mangeshkar Hospital, and we have seen pretty close to maybe 15,000 patients as a team for COVID-19, and from that viewpoint also, I will be giving you some tips while talking about lung involvement in COVID-19. So I don't know whether the topic has been introduced earlier, but just to begin and to set the stage right, I will have a brief introduction about the today's topic of lung involvement with coronaviruses. So there are 39 coronaviruses which are the known human as well as animal pathogens, and they are mainly causing respiratory and gastrointestinal disease. So even before COVID-19 was known, we knew 4 human coronaviruses and 39 total coronaviruses which could cause syndromes such as rhinosinusitis, pharyngitis, conjunctivitis, gastroenteritis, and they are the known human pathogens. But in December 2019, a new coronavirus was identified in Wuhan province of China as a cause of pneumonia and ARDS, and it used to cause a lot of deaths, and the investigators have found out that to be this virus called as SARS-CoV-2, which is severe acute respiratory syndrome coronavirus 2, and the disease which it causes is called as coronavirus disease 19. Now the disease has a big spectrum. Dr. Kadam has elucidated about it, that it can be very, very mild infection and asymptomatic one. From that it can range to pneumonia, severe pneumonia, acute respiratory distress syndrome, multi-organ dysfunction syndrome, septic shock, as well as death. And I'm sure all of the audience who's right now listening to this talk must have seen most of these manifestations happening in their patients and some of our relatives also. And the disease can cause 3 clinical categories: mild disease, severe disease, and critical disease. I'm not delving into this category because it's a different topic, but These are the broad clinical categories, and the management is also according to those clinical categories. The infection fatality rate was initially thought to be 2.5 to 5%, but with these 3 waves of this pandemic coming in, now we have finalized this mortality to somewhere between 0.5 to 1% in unvaccinated individuals, and in vaccinated individuals it is more than, there is a 90% reduction in this, even this figure of mortality. But the mortality will increase exponentially with age and certain risk factors that I'm going to elucidate in next few slides. So what are the risk factors when the disease progresses and just doesn't remain a simple viral infection of the throat, but causes a very bad pneumonia or lung involvement? What are those risk factors? So the commonest risk factors for disease progression are an active cancer, a chronic heart or lung or kidney or liver ailment, cerebrovascular disease, diabetes mellitus, obesity. Typically when the body mass index is more than 30, we can call it as obesity. So that has become an important risk factor for disease progression. Pregnancy, especially advanced pregnancy, is a risk factor for disease progression, and immunocompromised states such as HIV infection, organ transplant, then it could be solid organ transplant or a stem cell or a bone marrow transplant, or patients who are on immunosuppressive drugs, they are the hosts in which the disease can progress very fast. So how do we view lung involvement in COVID-19? So for the most people who are infected with SARS-CoV-2, the people will have only mild upper respiratory symptoms such as stuffy nose, runny nose, sore throat, and as Dr. Kadam had said earlier, a lot of pain while swallowing. Sometimes dysphagia can happen. People cannot even talk because of throat pain, especially with Omicron variant. The upper respiratory symptoms have become very, very common. And the symptoms such as loss of smell, that is anosmia, and loss of taste, such as dysphagia, were less common with Omicron, but still they are seen. So this is how the upper respiratory tract involvement starts with COVID-19. But this is not really the lung involvement that we are talking about. The lung involvement happens when the disease extends from the pharynx or larynx and below. So here it will produce first tracheobronchitis, then it will produce pneumonia, and in certain people the pneumonia may progress to produce something called as ARDS or acute respiratory distress syndrome. And it has been well documented that the Omicron variant can multiply to very, very high levels of viral load in tracheobronchial tree, and therefore it has been regarded to be highly infectious, more than 6 times than the previous variant of the SARS-CoV-2. And so tracheal bronchial tree is supposed to be the major area where the virus multiplies. The symptoms of lung involvement in COVID-19 do not begin immediately, but they typically begin 3 to 7 days after onset. In many people, the lung involvement or lower respiratory involvement can be asymptomatic. So they can have pneumonic patch over there, but they may not have any symptoms, or they may not have hypoxia at all. Some of them begin to develop a silent hypoxia in which their oxygen saturation starts falling, but they are not aware of it. And sometimes when they go to pass urine or motions, then they can develop a hypoxic spell and they can fall in the toilet. So that is has become really a common occurrence with these patients. And certain of these patients, when the disease progresses to a further level, the hypoxia doesn't remain silent, but they develop breathlessness on exertion. With minimal exertion, even with change of position, they can get breathlessness, and sometimes they progress enough to produce to develop this dyspnea at rest. So they are tachypneic, they cannot talk, and they have to break sentences and then they have to talk. So all of us have seen this spectrum of patients of lung involvement with COVID-19. Most of the people who have lung involvement develop cough. Almost 50% or more of them develop cough, but in most cases the cough is non-productive. Sometimes the cough is productive, and sometimes it is even likely to produce small amount of hemoptysis. So when a COVID-19 patient develops hemoptysis, and you get an infiltrate on the X-ray, that is a telltale sign that the lung involvement has started, and sometimes it could be an indication for admission. When the lung involvement progresses to a certain extent, then the patients become tachypneic at rest. They develop signs of respiratory failure. They start using their accessory muscles. So you can see the neck muscles. The patient is taking very deep breaths. Sometimes the lips or the fingertips get sinuous, and sometimes patients can get a collapsing episode or a syncopal episode. The single most important tool to pick up whether the lung involvement has begun in a COVID-19 patient or not is pulse oximeter. So many people ask me whether we should do ESR, whether we should CRP, whether we should read IMA, or whether we should ferritin, whether we should do LDH, whether we should do it every day, whether we should do it every hourly. So sometimes people ask extremes of questions, or whether we should do X-ray chest or CT scan. But as Dr. Kadam has said, that most of these investigations with Omicron variant may not be required because lung involvement is rare. But when Delta was there, what was your most important single tool to pick up the lung decision? That was the pulse oximeter. So if your pulse oximeter shows that the oxygen saturation is falling, it is going below 94, then that becomes the single most important tool to pick up the lung disease. And all clinical decisions are based upon the oxygen saturation and not on the biochemical parameters or on the lung or CT or X-ray involvement. So pulse oximeter, and pulse oximeter is the answer. So your patients who are home quarantined, whether they are beginning to develop lung involvement or not, or a patient who is hospitalized and whether his lung involvement is increasing or not, please monitor the oxygen saturation. That will tell you whether we do every hourly CRP or every daily X-ray or CT scan. It will not tell you, because once CT or X-ray shows pneumonic consolidation, I will tell you in next slides that it can remain for nearly 1 month and the findings may not change for 1 month. And that's why many people who are admitted, the relatives ask us whether his X-ray has improved, whether his CT scan has improved, when are we going to do next X-ray, when are we going to do next CT scan. I have to forcibly tell them that this is not required, because we are monitoring his pulse oximeter, we know he is improving or he is not improving. And we have to just make all decisions based upon the pulse oximeter, and we just cannot do random scans or X-ray just to show that the lung involvement has improved or not, or deteriorated or not. However, when they suddenly develop a desaturation episode, or suddenly their oxygen requirement increases, say from 2 liters, they suddenly want to 15 liters, then it makes sense to do some radiological investigation. But otherwise, once a baseline investigation is done, we generally do not recommend to do additional X-rays or CT scans for an admitted patient. Remember that lung involvement can also happen in COVID-19 because of causes other than COVID-19. So persons in second week of illness who are hospitalized, who have already received steroids because they were hypoxic, they can start getting bacterial pneumonia. So here in these patients, after 5 to 7 days of hospitalization or in the second week of illness, they start getting new fevers, new X-ray infiltrates, increased oxygen requirement, they start producing purulent sputum, and then we know that yes, maybe their bacterial pneumonia is in development, their CRP starts rising, their WBC starts rising, and that's how we diagnose the secondary bacterial pneumonia. So that can also happen in COVID-19. People can get lung involvement in COVID-19 with pulmonary thromboembolism, and that is a different topic altogether. But small or large, segmental or subsegmental pulmonary thromboembolism is another cause of worsening hypoxia in COVID-19 patients, other than the pure lung involvement with SARS-CoV-2 virus. Sometimes patients who are on steroids and who have got uncontrolled diabetes can get a fungal superinfection of the lungs. So they can get this entity called as kappa, that is COVID-associated pulmonary aspergillosis, or they can get this entity called as CAM, that is COVID-associated mucormycosis. And in these both fungal infections, large nodular consolidations appear in the lungs with central cavitation, and thereby we start suspecting that fungal superinfection may have occurred here. Some patients in the second or third week of illness start getting post-COVID fibrosis. So they start remaining hypoxic, their oxygen saturation doesn't just go up, or they develop a complication called as organizing pneumonia, which might entail us to increase their steroid dose a bit or to continue for a little longer time, more than the usual 10 days. So that is another secondary cause of lung involvement in COVID-19. And a physician should never forget that all these patients who are admitted sick and old can get a fluid overload state. Quickly they can get fluid overload because of poor cardiac contractility, pre-existing ischemic heart disease, or sometimes because of COVID nephritis. They can get this fluid overload state, and the poor oxygenation can be also because of fluid overload state, and that can also cause whitening of the lungs. And we might ascribe it to COVID-19, but it could be just fluid overload. So all these things a physician must understand before labeling that this patient is having COVID-19, and that is the cause of the lung involvement. These other causes also have to be taken care of and maybe have to be treated simultaneously. What is the pathophysiology of lung disease in COVID-19? How does actual lung disease happens in COVID-19? So as I told you, the Omicron variant reaches very, very high viral loads in tracheobronchial epithelium, and that is a multiplying site. And from there, it just sometimes just doesn't go into the lungs, just goes out and starts infecting other people. But the Delta variants, and in some cases, immunocompromised patients with Omicron variant start getting direct diffuse alveolar damage. Here, the alveolar pneumocytes, called as type 2 pneumocytes, they have the ACE2 receptors on their surface, and they can produce viral attachment, and virus can go inside these type 2 pneumocytes, can cause their apoptosis or death, and that produces hypoxia. Sometimes the virus can produce endothelial damage, producing microthrombosis within the pulmonary vasculature, and that can also produce very bad hypoxia. Most of the people have got neutrophilic response to this alveolar invasion, and that produces interstitial edema, pulmonary capillary congestion, and all these entities together produce a state of hypoxia, which can lead to respiratory failure and death. So whatever autopsies have been done in COVID-19 patients have just shown this picture: a diffuse alveolar damage, interstitial edema, and microthrombosis and pulmonary capillary congestion as a cause of pathophysiology of COVID-19 lung involvement. X-ray chest is the most easy tool to find out how this pathophysiologic process has involved the lung in a particular patient. Mind you that in a very early or a very mild disease, the X-ray chest can be completely normal in a COVID-19 patient. But as the disease progresses, sometimes patients start getting these consolidations and ground-glass opacities. And in a typical COVID-19 patient, these opacities are typically bilateral, mainly peripheral, and involving middle and lower lung zones. In most people, we have found that when serial imaging was done, nowadays we don't do serial imaging as I told you earlier, but earlier when we used to do serial X-rays in some patients, we found that in many people actually the pneumonic consolidations increased over a period of time. And then the peak severity used to happen at 10 to 12 days after onset, and then gradual resolution over next 1 month used to happen. Around 0.5% of people having severe COVID-19 can get this complication of spontaneous pneumothorax. So patient who is maintained on say 20% oxygen or just 2 liters suddenly start getting 50 liters of oxygen, becomes breathless, we get an accident and we find pneumothorax. This has happened, and we have inserted many ICDs in the COVID wards or COVID ICUs, and I'm sure that other physicians in this group will agree that this can be a complication of COVID-19 infection. The most important finding today that we are going to discuss in lung involvement is COVID-19 chest CT findings, because everybody wants to know when to do a CT scan and what to see in the CT scan. So Dr. Kadam has already told you that in most patients you will not need a CT scan, but for those people who are having risk factors of disease progression and by day 5 to day 7 they are not already better or home quarantine, if we obtain a CT scan, it may be useful. So understand that chest CT, you do not need to use contrast while you are imaging a COVID patient, because contrast doesn't put much doesn't bring out much more important information in most patients, except when you are expecting pulmonary thromboembolism. Then contrast is much. But for a routine CT scan of COVID patient, you do not need contrast. Meaning of these patients can have COVID nephritis. They may be already taking NSAIDs, and using contrast can put them at the risk of acute kidney injury. So just do a plain CT scan in patients who don't develop symptomatic improvement in the next 5 to 7 days after onset. But remember that CT scan can pick up findings of suggestive of COVID-19 in a more sensitive fashion, better than X-ray. But these findings are not specific. And in next one slide, I will explain in that sometimes we can get fooled with CT scan. So they are not specific for COVID-19, but what we commonly see are ground glass opacities with or without consolidations, which are consistent with any viral pneumonia. So there is no specific as such finding which is specific to SARS-CoV-2 or COVID-19, but it is in general, as you see in any viral pneumonia, you will see ground glass opacities and consolidations. And we have seen temporal evolution in many patients in that first their CT scan is normal, then they start developing ground glass opacities in the peripheral and subpleural regions. Then at the same areas where the ground glass opacities are, they start developing consolidation, and after a few weeks, they are getting resolution at that place. So if you see this table, it will detail out that what kind of findings you will find in chest CT scan of COVID-19 patients. So we get ground glass opacifications in nearly 83% of patients. 60% of them shows ground glass opacities plus consolidations. Adjacent pleural thickenings in nearly 50% of patients, interseptal lobular septal thickening in 48 patients, and a proper consolidation like a bacterial pneumonia with their bronchogram in nearly 48% of patients. So in this slide, I will show you that if you could see that this is a CT scan which shows that multiple segments of the lungs are showing these ground glass opacities, and this is very, very typical. They are generally peripheral and they are typically subpleural in location. As you can see, this opacity is subpleural in location and peripheral in locations. How peripheral is it? And relatively, the central portions of the lungs are spared. So if you see such a CT scan, even at sleep at 3 o'clock in the morning, we can say that, oh, this looks like a COVID-19, but mind you, this is not specific for COVID-19, but it is suggestive of COVID-19. So many physicians and many general practitioners and even many specialists, they are interested in how this CT chest scoring is done. So CT chest scoring of the severity is done according to the involvement of lung segments. So typically the right lung is divided into 3 segments and left lung is divided into 2 segments. So total 5 segments of both lungs, and in each segment, if less than 5% of the lung is involved, you add a score of 1. If between 5 to 25%, you add a score of 2, 25 to 50, score of 3, 50 to 75, score of 4, and more than 75% of that segment is involved, score of 5. So you calculate score in each segment and then total it out. So if it is 12, then it will be 12 out of 25. If it is say 17, it is 17 of 25. And typically scores less than 8 are called as mild pneumonia. From 8 to say 15 or 16 are called as moderate, and from 16, 17 onwards till 25 we call it as severe lung involvement. So that is how the score has been done. In some areas they score out of 25, and in some areas they score out of 40. Remember that higher the score means there is a greater severity of lung involvement, and generally it correlates with patient's conditions, the oxygen requirements, as well as their prognosis. So people who have got higher score have got poor prognosis. A lower score can have generally a better prognosis, but sometimes you see patients in both categories. People with higher scores are not hypoxic at all. People with lower scores are sometimes hypoxic. So sometimes that also is seen. But in general, higher the score, more the severity and more the chance of mortality of that patient going on to ventilator. What is this CORADS? So many physicians are also interested in asking what is this CORADS. CORADS is a score given by radiologists. So from CORADS 1 to CORADS 6 scores are there. So if a patient has a proven RT-PCR positive disease, it is called as CORADS 6. That means it is 100% COVID pneumonia. If that PCR is not there and only radiologically will have to tell whether it is COVID or not, then the CORADS 1 to 5 category is there. So from 1 to 5, as you go from category 4 as 1 to category 5, the confidence of radiologist is much more to say that yes, this is COVID. So when it is 4 as 1 or 2, radiologist is not very sure whether it is COVID or not. But when it is 4 or 4 or 5, the radiologist is becoming more and more confident that yes, this is a possibly COVID pneumonia. So if it is 4 and 6, it is 100% COVID. 4 and 5, yes, much more likely COVID. 4 and 1, 2 and 3, maybe may not be COVID. So like that, you can infer the meaning from 4 and 1 to 4 and 6. There are certain less common CT chest findings, such as sometimes you can get a crazy pavement like pattern or bronchiectasis or pleural and pericardial effusions and mediastinal lymphadenopathy, but they are not very common findings, and they are actually rare findings in COVID-19. But yes, in some patients we have seen these kind of findings, but they are not very specific for COVID-19. But remember that somebody who comes to you and shows a CT scan and the radiologist has shown that okay, there are groundless opacities, this is 4 at 4, 4 at 5, and this is a good chance that it is COVID, and score is also given 7 out of 25. Sometimes you can get fooled, but these people actually may not have COVID, and they may have other viral pneumonia such as H1N1 pneumonia or adenovirus pneumonia, or in HIV. I have seen many HIV positive people landing up with PCP pneumonia in COVID wards because their CT scan was reported by radiologists as COVID-19. But typically, if you see PCP, you get a peripheral sparing and you don't get that peripheral groundless opacities. Generally, PCP opacities are central, they are mainly central, and there is a peripheral sparing. So if you just see the CT scan carefully, sometimes you can say that this doesn't look like COVID and this may be PCP. But really, you'll have to get time out from your busy practice and see each and every image yourself. And I have seen at least 10 to 15 PCP landing up in COVID wards, unfortunately, being labeled as COVID-19. Good part of this is that they receive steroids, because in COVID-19 we give steroids. But bad part is that they don't receive the Bactrim DS or trimethoprim sulfamide, which is drug of choice, and sometimes they can die. So PCP sometimes can get fooled with COVID-19. Then patients with cardiac diseases, cardiomyopathies, and renal failure can get fluid overload, and sometimes their CT scan or X-ray is indistinguishable from COVID, and therefore they may land up in COVID, but they are not COVID. And one has to really, if you see that a patient is coming with very bad lungs, you are diuresing the patient, within 2 days the oxygen requirement goes, then you start suspecting whether it was a fluid overload state and whether this is not COVID, because COVID pneumonia will not improve in 2 days. From oxygen requirement will not come down from 15 liters to 2 liters in just 2 days. So that thing happens. You start suspecting that it could be fluid overload. And sometimes other diseases such as non-specific interstitial pneumonia, cryptogenic organizing pneumonia can also manifest like COVID-19 changes on CT scan. Now I'm coming to the last part of my talk. What is the sequelae of lung disease in COVID-19? So we all know that in acute stage, COVID can be a killer, but though in those people who have crossed, say 2 weeks of COVID-19, or they have crossed say 1 month of COVID-19, now they have got discharged or they are about to be discharged after a long stay in the hospital. What happens to their lungs? What is the sequelae? So in my experience of last 1.5 years, and maybe other experts will also opine, most of the survivors of COVID-19, they recover either fully or sometimes partially. They can keep on getting cough and exertional dyspnea for a few weeks after discharge, but generally with supportive symptomatic treatment, it just eventually they will improve. In some people, they get very low 2-3 liters of oxygen requirement for very few weeks. Sometimes it just doesn't increase, it just doesn't decrease, and they're like stuck on that oxygen requirement. And sometimes they can get a permanent dependence on NIV or ventilator dependent, but these events are rare. A permanent NIV or ventilator oxygen dependence is rare. But some people who get complications such as post-COVID fibrosis of the lungs or organizing pneumonia, they can get this very bad sequelae of lung disease, and they can be permanently oxygen bound. But I will tell you in my experience that these patients are rare. At the end of 6 months after recovery from COVID, I have seen that most patients were oxygen free, except a few. Most patients were oxygen free. In some people, even after their primary disease they recover, they just don't recover from the hypoxia. It is not possible to bring them off from ventilator, or they go on this entity called as ECMO, extracorporeal membrane oxygenation. And in these people, really things are difficult because they eventually will need lung transplantation. And I remember in that last 1.5 years from Dinanath Mangeshkar Hospital where I practice, we have referred 6 patients for lung transplantation. But the lung transplantation results in our country are not good, and 5-year survival rates of lung transplantation are very rare. But it is going to be ultimately a very rare outcome of COVID-19. Either it will kill or it will survive. But eventually, lung transplantation requirement is going to be a rare eventuality in most people. In people who require significant oxygen support because of post-COVID fibrosis, we can put them on home portable ventilator, and we have definitely, I remember few patients who have been sent home on home portable portavent, small ventilator or home oxygen concentrator, or some people who were pretty obese and they had a obstructive sleep apnea element. We had discharged them on this nasal CPAP. Some people who develop pneumothorax as a sequel of COVID-19 will require ICD placements, and sometimes they will require even other measures for pneumothorax. And it is very important to imbibe on patients' mind who are admitted right now and are hypoxic to what is the importance of breathing exercises and incentive spirometry. If they do that religiously every hourly, then generally I think their outcome should be good. And this is the neglected entity in our field, respiratory rehabilitation, but it is very, very important for people who have got lung involvement in COVID-19. Respiratory rehabilitation is a separate evolving entity, and definitely one has to give a due attention to this evolving specialty. Some people who have got very bad lung involvement, who have got ARDS, get persistent positive PCR, but generally there is no specific treatment required for this persistent positive PCR because it might just represent a dead virus or sometimes very rarely reinfection, but we generally do not treat a persistent positive PCR. So I think this was about the sequelae of COVID-19 that I wanted to talk about. So I'll end my talk now, and if the organizers permit me, let us open the topic for question and answers.
Sir, I have a question. You mentioned the score could be either of 25 or 40. Could you explain that variation?
So see, in Pune city, we are getting a score of 7 of 25, 12 out of 25, 17 out of 25. So as I told you, on the right side of the lung, they have made 3 segments. On the left side of the lung, they have made 2 segments. So there are like 5 segments. And in each segment, you calculate score, how much that segment is involved. So each segment will have say 2, 3, 4, 5, something like that score. And it will add up to become something out of 25. When you are calculating out of 40, so here people from Kolhapur and Sangli, that those areas, they are reporting up to 40. So what they do is they divide each lung into 10 parts. So here 10 parts on the right side, 10 parts on the left side, so it will become total of 20. And if each part is affected less than 50%, you get 1 score, and more than 50%, you get 2 scores. So this total score becomes 40. So they will calculate according to that score and give you the score. Is it clear?
Yeah. Any international guidelines on this about scoring?
So there are no international guidelines, but I think what it is called is MBRIA, Maharashtra Radiologists Association. They have a guideline. I've got their document on my WhatsApp. So there is a guideline how to report it. So I don't know whether you can see on this. Oops. So that's how this document says, and it guides the radiologist how to report it. So I think most of the radiologists are going by this document.
So there's a question. Does regular breathing or pranayama exercise help reduce chest-related symptoms?
See, I think the post-COVID or COVID sequelae symptoms are more of non-specific symptoms, because how many times you examine them, you don't get any specific findings in them. But they keep on complaining of dyspnea, they keep on complaining of cough, they keep on complaining of lack of exercise tolerance. So in these people, to build up their lung capacity, I think all these exercises, whether it is Anulom, Vilom, Pranayam, whether it is Bhastrika, or whether it is other breathing exercises, incentive spirometry, breath holding, all these things should be definitely encouraged, and it will definitely help to some extent. It will not resolve all the abnormalities, but it will build up their exercise capacity.
So in the chat box, there are no more questions. We thank you for enlightening us about the lung involvement in COVID-19. And on behalf of IMA Pune, I request our President, Dr. B.L. Deshmukh sir, to felicitate you virtually with a bouquet and a uparna.
So this is bouquet.
Thank you. Thank you so much, Dr. Kedar sir, and thank you, B.L. Deshmukh sir. Thank you.
Thanks for joining. Next, in the continuation, we have with us Dr. Amit David. So he is going to speak us on rational use of antivirals in COVID. Dr. Amit David is a consultant in HIV medicine and infectious diseases at Ruby Hall Clinic and Pune Hospital, and has his own consultation as well. And he has done extensive work in HIV. He's been awarded scholarships to attend various international conclaves in France, Croatia, UK, and has the EACS scholarship for AIDS conference in Barcelona, Spain. He's a member of American Academy of HIV Medicine, AIDS Society of India, International AIDS Society, and European AIDS Clinical Society. And he has various publications related to HIV and infectious diseases, tuberculosis in particular. So we welcome Dr. Amit David for his talk.
Thank you, Kedar. Can you hear me?
Yes.
Yeah. So I'll share my screen now. Can you see my screen, please?
Yes.
So at the outset, thank you, IMA Pune, for inviting me for this webinar. And the topic which is given to me is rational use of antivirals in COVID-19, especially in the context of the Omicron variant, which is now raging all over India and is now causing the third wave, which is on us in Pune. I'll talk in English and Marathi both, so that majority of the audience can get the message which I'm trying to give. So, as I've always said, that this is the virus which we are trying to tackle, and every time I say that time has come to re-engineer our definition of weapons of mass destruction. So as of now, this 160 nanometer virus is the new weapon of mass destruction. It has killed lakhs and lakhs of people all over the world. I think the latest count was it has killed more people than those who were killed in World War II. So you can understand, we spent so much time on acquiring weapons. A 160 nanometer virus introduced into a population which has zero immunity at that time when it came into our population can do the same job. So that is what it has done, and that's why we are taking it so seriously. It is a family of coronavirus, and this is the spike protein which is embedded all over the virus, which gives it the crown shape or coronavirus, and that's why the crown shape, that's why it is called as coronavirus. So this is the spike protein against which multiple of our antibodies are targeted against. This is the spike protein which is being used in our vaccines. So we will now come in future, we will come to know how this antiviral therapy has changed over the last 3 months and how it might evolve in the future. At the outset, I would like to thank all my staff at Noble Hospital, which has been at the forefront of leading against the COVID pandemic. We have admitted around 6,500 patients with a mortality of around 7.5%. And it would not have been possible. I would not have learned anything about COVID if I had no cooperation from the entire healthcare staff, right from the director down to the class 3, class 4 workers who taught me a lot about how to manage COVID. And hence this slide is to acknowledge their efforts as well. I am just the face, they are the real heroes in this pandemic. So we have multiple variants, and the UK has mentioned all these variants. This is the NHS data, where it is clear now that we started off with the Alpha variant, which started in UK, then went to the Delta variant, which was there in India. And now this is the Omicron variant, or which is called as B11529. And this Omicron variant has developed 3 babies, BA1, BA2, BA3. So this is the variant which is now currently circulating in India. And in Pune, BA2 is the predominant variant, which is there. Genome sequencing from Noble Hospital has clearly shown that we are having the BA2 as the predominant variant in India. So we started off with Alpha, then came to Delta, now we are at Omicron. How did it come about? This was the province in Gauteng, where Johannesburg, or in South Africa, where Johannesburg is the capital, where they suddenly showed that within a matter of 15 days, there was an explosion of cases which occurred so fast that the cases went from only tens to thousands in a matter of 15 days. And I must say that the South Africans have the best genome sequencing surveillance in the world, at par with what United Kingdom is doing, because of which they could pick up that a new variant is in circulation. And this was then labeled as the blue dot. You can see initially it was the beta variant in South Africa, then the Delta variant, which was common in India. And suddenly this genome surveillance started showing that this is the blue dot, or the Omicron variant. And it was so fast that within 15 days, it completely replaced the Delta variant, which was circulating. And similarly, the same thing has happened in India, where Omicron, within a matter of a month and a half, has completely replaced the predominant Delta variant, which was circulating in Pune. So if we have the genome sequencing data, which just came in for Noble Hospital today, the Delta variant, which was almost 100% 2 months back, is just 3% now, while the Omicron variant is 97%, and BA2 is the predominant with 44% of samples showing the Omicron BA2 variant in Pune. So this is the data as of today. So you can see how fast it has completely replaced, outcompeted, outgrown already fit Delta variant. So you know how fit it is, that it can outcompete an already fit variant. So this is now the predominant variant. You can see in US the same thing has happened. From 12th of November to 1st of Jan, this Omicron, which is there in this violet graph, has gone from 5% to 99% in a matter of 1.5 months. So this is how it has completely replaced Delta. And because it has replaced Delta, it has changed the way we are thinking as well. What has happened in India? There was a sudden, see, we were reporting at 0% test positivity rate in certain states. All India, that positivity went from 0% to 23% in just a matter of 2 weeks. You can see how fast it is growing, that it has gone from 0% to 23% in a matter of 15 days. Gradually it is coming down, but we should be aware that it should not go back again. So that is what we have to guard against. So what happens and why is Omicron worrying people? And it is worrying people because it has 47 mutations which are new, out of which 29 are there in the spike protein itself. So you can see all these 47 mutations, and that's why the scientists were amazed as to how one variant accumulated 47 mutations in such a short amount of time. 29 of those mutations were in the receptor binding domain of the spike protein. So you can see the spike protein mutations were predominant. And we are having our monoclonal antibodies against the spike protein. We are having the vaccines which we are manufacturing with the help of the spike protein. So if the spike protein has 29 new mutations, you can understand how worried the scientists would be. And the worries came true because it is clear that this variant can resist the neutralizing antibodies which are produced by vaccines neutralizing antibodies which are produced by prior infections, because of which it gets an immune escape phenomenon, because of which even if you had past alpha infection or past delta infection, you can still get Omicron during the third wave. If you have had taken vaccines to protect against alpha and delta variant, this vaccine has reduced neutralizing capacity against the Omicron variant, because of which immune escape can occur. So that is why people started worrying. And then there was another worrying news that the monoclonal antibody cocktail, which we were using up till now, which we were using so successfully against the Delta variant, the news came in that maybe that monoclonal antibody cocktail cannot work against the Omicron variant. So more and more data about increased transmissibility, increased growth, resistance to neutralizing antibodies developed by infection or vaccine, and resistance against therapeutic monoclonal antibodies came up, because of which everybody got really worried about the Omicron variant. So now we are here. So we are here against the Omicron variant, and now we have to tailor our antiviral therapies or tailor our therapies. Can I ask the organizers to please mute everyone?
Dr. Ingre sir, can you please mute your mic? Yeah, you can proceed, Amit.
Thank you. So, as I said, more growth, more transmissibility, more infection, with the capacity to resist neutralizing antibodies developed by vaccines, developed by natural infection, and also the ability to resist therapeutic monoclonal antibodies. So this is what the variant has brought in. The symptoms of this variant are not much different from Delta, except sore throat is a very common symptom which is shown in Delta. So it's shown in Omicron, which is not seen in Delta, while loss of sense of smell or taste, which was there in Delta, is not routinely seen in Omicron. So these are the only two symptoms: sore throat, which has become more common, and loss of sense of smell and taste, which has become less common. So these are the symptoms which the patients are coming in because of Omicron. How is the hospitalization capacity and how is the death rate? So now there are more and more studies which are clear that if you have Omicron infection, the risk of being admitted to the hospital for Omicron is 65% lower if you have 2 doses of vaccine, and 81% lower as compared to an unvaccinated person if you have 3 doses of vaccine. So if you are fully vaccinated or boosted, your risk of getting admitted is reduced by anywhere between 65% to 81%. Similarly, mortality because of Omicron is around 10 to 15% as compared to Delta variant. So it is a less chance of hospitalization, less chance of landing up in ICU, and less chance of dying because of Omicron. So although Omicron is more infectious, although the growth is much faster, but nature has taken away the killing capacity which it had given to Delta. So it is a lesser killer, and it leads to lesser hospital admissions, lesser ICU admissions, lesser mortality. But that doesn't mean that our hospitals won't pile up. Remember that it can lead to cases twice or thrice that much of Delta. So if that many cases are there in India, and even if the small percentage get admitted, we will have hospital wards full, we will have ICU wards full. So okay, it is a lesser killer, but that doesn't mean it doesn't kill at all. That doesn't mean that it doesn't land you in ICU at all. So remember, take it seriously, and we need to strike Omicron when we identify it early. So then what are the therapeutic agents available? We know that Omicron rapidly proliferates. It's very infectious. If one person in the family is positive, then no time 8-10 members in the family can get positive. But do we have drugs now to tackle this Omicron variant? What drugs do we have? So now we have multiple antiviral agents. Some of them are available in India, and some of them will come in India very, very soon. And I'll be talking about these antiviral agents in my further slides. First is Paxlovid, or what is called as Nirmatrelvir Ritonavir, which will be, and once it comes into India, it is not available in India, but once it comes into India, it will be the #1 oral therapy against Omicron or against any future variants which come into India. Secondly, will be molnupiravir, which is available in India. It's an oral antiviral agent against Omicron and further variants. Third is interesting data about early onset remdesivir. We have used remdesivir for almost 18 months now, but now there is new data available that earlier use of remdesivir can be an effective antiviral strategy against the Omicron variant and against all further variants which might land up in India. Then concerning data about the casirivimab, imdevimab, regeneron cocktail, where we used to use it earlier and where we can use it now, I'll let you know. Then there is sotrovimab. This is another monoclonal antibody not available in India as of now, but will be available in India very soon. What about steroids? Tocilizumab and blood thinning agents or low molecular weight heparin. Steroids were useful during cytokine storm. Tocilizumab was useful during cytokine storm. Their use will remain even if patient goes into cytokine storm because of Omicron. Blood thinning agents, the guidelines will remain the same as it was during the Delta pandemic. So these three drugs I am not going to talk about. Steroids, tocilizumab, blood thinning agents, the indications remain the same. I am not going to talk about them, but I will talk about 5 antiviral drugs which might help us change the landscape of Omicron. They are Paxlovid, molnupiravir, early onset remdesivir, casirivimab, imdevimab, regeneron cocktail, and sotrovimab. So here we go. First, I always show this slide because I need to emphasize on general practitioners when they have to use which drug. Remember, there are 2 phases in this the life cycle of any variant, be it Omicron, be it Delta, be it Alpha, be it original Wuhan, that the virus has 2 phases or the disease has 2 phases. The first 7 to 10 days is known as the viral response phase, where the viral load in the body is very high. You start getting symptoms like fever, cough, cold, sore throat, body ache, headache. That is when the virus is circulating in your body and there is hardly any immunity. This lasts for 7 to 10 days. So if you want to use your antivirals, which I have talked about, you want to use it rationally, remember that the time to use an antiviral is in the first 5 to 7 days of onset of symptoms. If you don't use it here and you try to use it here, then their efficacy will be there in certain antivirals, but it will be much, much lesser than when you can use it here. So remember, first 5 to 7 days, that is when you use your antivirals. After 7 days, the body's immunity wakes up. In most of the times, the immunity is good, it is functional, it destroys the virus, and you have a self-limiting illness, and that is what we call as asymptomatic or mild illness. But in certain cases, in certain immunocompromised people, in certain elderly people who have dysfunctional immunity, this inflammatory response can become exuberant, hyperinflammatory, landing up in cytokine storm, and that is when the patient becomes breathless, lands up on oxygen, requires ventilator, and then can go into the ICU. So if you want to use your anti-inflammatory agents, your steroids, your tocilizumab, your baricitinib, use it during the next 7 to 10 days, the second half of the disease. If you want to use antivirals, you use it in the first 7 days. Many times, general practitioner prescribes steroids, which are anti-inflammatory drugs during the viral response phase. And if you do that, remember what will end up is having the mucormycosis epidemic, which we had during the second wave. Majority of the cases happened because many people who were in their viral phase got prescribed steroids. So steroids only for those who require oxygen or those who are hospitalized. No OPD patient who is COVID positive, be it any variant which comes in the future, should get steroids as an OPD prescription. Steroids should be a prescription only for people who require oxygen or who are hospitalized, not for OPD patients. So antiviral should be a prescription for OPD patients. Steroids should be the prescription for IPD patients. If we do that, we will have done a great job. That is the first take-home point which I want to give all my general practitioner friends. So now we move on. The drug which will change the landscape of COVID in the future, I am sure, is Paxlovid. And this was quoted in the Science Journal just last month, where it has been touted by all scientists that is the pill which can be given on OPD basis, variant proof, and which can help majority of our patients. And why is it so? I'll let you know. So where does Paxlovid act? So Paxlovid is a protease inhibitor. Remember, we used lopinavir, ritonavir during early days of our pandemic, and then we decided that it was not working for COVID inhibition. Remember, the drug was wrong, but the target of action was correct. The target of action was this protease inhibitor, protease enzyme, which if inhibited, the life cycle of the virus inside the cell completely stops. This RNA cannot prepare baby RNAs, because of which baby viruses are not formed, because of which they cannot come out of respiratory epithelial cell. The life cycle gets terminated, the virus dies, and the patient gets better. So this is where the protease inhibitors come in. Lopinavir was our first protease inhibitor. It did not work, but Paxlovid is the second protease inhibitor and it does work. So the drug might be wrong, but the mechanism of action was not wrong. We were right in thinking that giving a protease inhibitor might help our patients. So what is Paxlovid? Paxlovid is the trade name for Nirmatrelvir ritonavir. And if somebody has worked in HIV, you must know about ritonavir, because ritonavir is a pharmacological booster. It is not an antiviral per se. What it does, it prevents nirmatrelvir from getting metabolized by the liver, because of which the nirmatrelvir levels go up and more killing capacity comes to this drug. So active drug is nirmatrelvir. Ritonavir is just a pharmacologic booster. It has been given emergency use approval by the US and the Europe for high risk patients who are more than 12 years of age and about 40 kg. In patients who had comorbidities or patients who were elderly, if Paxlovid was given within 5 days of onset of symptoms, then the risk of progression to severe disease and death was reduced by an incredible 90%. Remember, monoclonal antibody cocktail gave an efficacy of only around 70%. So one oral pill given for 5 days on OPD basis was during mild phase of the illness to people who have comorbidities or who are elderly, was giving 90% protection from progression to severe disease and death. So that was the data which really fired up the imagination of all consultants, because of which it was given a full drug application in early 2022. So it is a protease inhibitor. Ritonavir just prevents the breakdown of nirmatrelvir and keeps the active levels high, and because of which it can kill the virus. As of now, in laboratory studies, Paxlovid works against all variants, including the Omicron variant. So we don't need to worry. This drug is an oral drug given on OPD basis, and it is variant proof. It works against alpha, beta, gamma, delta, Omicron, and maybe in future, if any variant comes, if the virus doesn't develop resistance to Paxlovid, it can kill any variant which comes into India. So it works against all variants. The dose is 2 tablets of nirmatrelvir and 1 tablet of ritonavir. That means 3 tablets morning, 3 tablets night for 5 days. So it's a blister pack packaging, and hopefully within this month, this drug will hit the Indian markets. And I'm sure when it hits the Indian markets, it will replace all other drugs, because the efficacy is there, side effects are less. Yes, ritonavir does has interaction with other drugs, but that can also be curtailed because it has to be given only for 5 days, and the stoppage of progression to severe disease is almost 90%. So this drug is the blockbuster drug which Pfizer has brought. I'm sure it will be #1 drug when it comes into India. Now we go to molnupiravir. Molnupiravir is the antiviral which is available in India. Almost 13 companies are marketing molnupiravir. What is the data about molnupiravir? So this trial was published in NEJM, where again, what does molnupiravir do? Molnupiravir is an RNA-dependent RNA polymerase inhibitor. What is RNA-dependent RNA polymerase? You must know remdesivir was the first RNA-dependent RNA polymerase we had. Molnupiravir is the second RNA-dependent RNA polymerase we have. What it does is it gets molnupiravir enters the viral RNA, and once it enters the viral RNA, it allows the RNA only to add adenine or guanine. It does not ask the RNA to add cytosine or thymine, because of which the RNA gets terminated. As the RNA is terminated, a fresh virion is not formed. Fresh virion is not formed, it cannot exclude the cell. So what remdesivir was doing 3 months back, the new drug molnupiravir is doing today. So molnupiravir and remdesivir are similar mechanism of action. Lopinavir and Paxlovid, similar mechanism of action. What did the scientists do? They picked up patients who were elderly or had certain comorbidities. Majority of them had obesity, some of them had diabetes, some of them had hypertension. They picked up these patients. They had to come within the first 5 days of onset of symptoms. They had to be of any variant. They were prescribed molnupiravir for 5 days or placebo for 5 days. And they found that molnupiravir reduced progression to severe disease and death in this category by almost 50%. When the whole data came in, then the efficacy was of prevention of progression to severe disease and death was 30%. So still it was giving almost a 50% protection when used at the right time in the right population. So it was used for elderly people. It was used for people with comorbidities. Remember, it was not used for young people without comorbidities. All these studies are conducted in people who are elderly or who have comorbidities. So the second take home point is, if you want to use an antiviral, remember your target population. Your patient has to come to you within the first 5 days. He has to take an oral tablet for 5 days, and he should be either elderly or have some comorbidities. Which comorbidities I will mention in my next slide. Only then these tablets will work. Please don't give your antivirals left, right, and center to any person who has COVID infection. It is not meant for all of them. This way we will fuel resistance to these antivirals. So remember, use your antivirals at the right time in the right population. So when they looked at the subgroup analysis, they found that in majority of the subgroups, molnupiravir was working fine, but there were certain problems with molnupiravir. So that's why molnupiravir was discredited. One was, if you are diabetes mellitus, then molnupiravir and placebo were almost having the same efficacy. If you have past COVID infection, molnupiravir was not doing much difference. Similarly, this trial was done in unvaccinated people. So people said, how will it work in vaccinated population? But remember that majority of us have got those 2 doses of vaccine 6 months back. Our immunity against Omicron, if we have not taken booster, is already at a very, very low level. So as of now, we are unvaccinated against Omicron. Majority of us, some of us have taken boosters. So majority of us are unvaccinated, and hence I feel that even in Pune, there is an unmet need for using molnupiravir, especially in people who are elderly, above 65 years of age, or who have comorbidities, especially non-diabetic comorbidities, where it has shown a good mechanism of action, good efficacy, and reduced chance of progression to severe disease. So you can see the deaths in molnupiravir were only 2, while there were 12 deaths in the placebo arm. So the death reduction was almost 87%, while progression to severe disease reduction was almost 50%. So that way, this drug does qualify, especially when Paxlovid is not available and people don't want to get admitted for remdesivir. This is a good option for people who are elderly or who have non-diabetic comorbidities, because in diabetes patients, this did not show to be very effective than placebo. Secondly, it is said to have teratogenicity in animal studies, because of which if your patients are pregnant or are wishing to get pregnant, we do not give them molnupiravir, or if we give them molnupiravir, we ask them to practice contraception, male contraception for a period of 3 months, female contraception for a period of at least 4 days after the tablet stops. So remember, there are certain problems with molnupiravir, but the data there is quite good. It does work, especially used in the right population at the right time. What about remdesivir? So remember, initially we used to use remdesivir in people who had moderate disease and who were admitted. So we used remdesivir during the first wave and the second wave after the NEGM trial said that in people who required oxygen, or in people who were in ICU and required HFNO, or in people who required NIV, or in those people who required invasive mechanical ventilation, they gave remdesivir, and found that if you give remdesivir to people who require oxygen, then your risk of resolution of symptoms is much, much faster. Your symptoms resolve 4 days earlier. You come off oxygen, come off NIV, or your need for requirement of NIV, requirement of oxygen goes down drastically. However, remdesivir does not have a survival benefit. So remdesivir, when used in hospitalized patients who require oxygen, leads to faster resolution of symptoms, lesser progression to invasive mechanical ventilation, but has no mortality benefit. That's what the NIH trial showed us, and it was effective in all the populations which was there. So giving remdesivir to hospitalized patients then started, and then every patient who was admitted in the hospital for moderate to severe disease ended up getting remdesivir for 5 days. And that is where the trial was, and that is where the evidence was until 1 month back. But this trial got published in NEGM just 1 month back. And what they said was that instead of using remdesivir during the moderate disease phase, when the person requires oxygen, or the person requires HFNO, or the person requires NIV, why don't we use it earlier during the viral phase? I have said that remdesivir is an antiviral, and it was counterintuitive to use remdesivir after 7 days of illness, because moderate to severe disease will occur after 7 days of illness. So they said, let's use it earlier in the first 7 days of symptoms. So that is what this trial did. Again, it included people who were elderly or who had comorbidities. Which were the comorbidities? Obesity, diabetes, hypertension, or age. These were the 4 comorbidities they looked at, and this was more representative trial, much better done trial than the molnupiravir trial. And they gave patients 3 days of remdesivir, not even 5 days of remdesivir. So if there were patients who were elderly or who had comorbidities, who had come to them within 7 days of onset of symptoms, they had to be unvaccinated. Then they gave them either 3 days remdesivir or 3 days placebo. They gave this remdesivir on day care basis. So for them, they did not admit the patient. They gave the remdesivir on day care basis. And they said, let's look whether these patients do progress to severe disease or death. And they found that giving remdesivir led to almost an 87% reduction of progression to severe disease. However, we have to point out that there were no deaths in either arm. So the placebo arm also was no death, remdesivir arm was also no death, but admission in casualty, admission in hospital, requirement of ICU reduced by almost 87%. So that's where it was clear now that we were actually giving remdesivir a bit too late. Giving remdesivir early, especially in the first 7 days, actually was the right thing to do. And this trial clearly showed that in people who are elderly, people who have severe comorbidities, giving remdesivir within 7 days of onset of symptoms, sometimes on day care basis for only 3 days, not even 5 days, can reduce your risk of hospitalization. And especially those who are elderly, those who are diabetic, because molnupiravir has a problem with diabetes, it's still not clear whether it is useful or not. There, obese, elderly, diabetics, their remdesivir can be a very, very good option, especially because monoclonal antibody cocktail will not be able to be used against the Omicron variant. So this trial then gave us more evidence that apart from Paxlovid, apart from molnupiravir, there is a third antiviral which we were using for so long, but we were using a bit late. Given early, it can also do a great job of preventing progression to severe disease. And remdesivir advantage was that across all subgroups, it was helpful. So whether your patient is above 60, male, diabetic, obesity, hypertension, any subgroup, remdesivir was better than placebo. So if your patient is elderly, above 60 years of age, or if he is diabetic, which many of our patients who develop COVID are, then if they have severe comorbidities, that means if your HbA1c is more than 8, if they are above 65, they are 70, 80 years of age, come to you within the first 3 days, you know that there are multiple comorbidities in this patient, then getting them admitted for 3 days and giving them remdesivir is a sure shot option. And remdesivir will work against all variants. So it's again another variant proof medicine. So it will work against Delta, Omicron, all variants, and it will prevent progression to severe disease and death. So this is another antiviral which if used rationally in proper patients, we can do a good job of not letting our patient progress to severe disease. Why do we want the patient to improve early? Because once the patient progresses to severe disease, his need for ICU can be for months. His need for ventilator can be for months. He can occupy the hospital bed for months. And we don't want that. We don't want the Delta wave where our hospitals were full, our ICUs were full, and we had to turn away non-COVID patients, although they required emergency care as well. We don't want that. And molnupiravir and remdesivir are 2 drugs which can help us achieve that during the Omicron pandemic. So same goes here, giving remdesivir reduced hospitalization, reduced need for casualty admissions, reduced need for hospitalization by almost 87 to 89%. What about casirivimab, imdevimab, monoclonal antibody cocktail? So many of us have used it during the last 6 months. Why did we use it? Because NEJM trial clearly showed that again in elderly patients with Delta variant infection, or elderly or young patients with comorbidities, giving the casirivimab, imdevimab cocktail 1.2 gram in the first 5 days reduces risk of progression to severe disease and death by almost 70%. So it was doing a fantastic job during the Delta pandemic, especially towards the end of Delta pandemic when it got available. We gave it to so many patients who required it and they did not progress to severe disease and death. You can see here, it was very, very active against the Delta variant. So that's why we started using it. And it was again, monoclonal antibody cocktail was working against all variants up till now. It was working against the original Wuhan strain. It was working against the alpha strain, the beta strain, the delta strain, which was available, which was there during the second wave in India. Whether we were using it in hospitalized patients, yes, we were using monoclonal antibody cocktail in hospitalized patients who were severely ill as well. because the recovery trial told us that if your patient is severely ill, that means he's on oxygen or he's on HFNO or he's on NIV or he's on invasive mechanical ventilation and he is seronegative, that means his antibody to nucleocapsid and antibody to spike is negative, that means he has no immunity to the COVID virus. Giving such a seriously ill patient monoclonal antibody cocktail for the Delta pandemic reduced the mortality from 30% to 24%. So not just early, this was the only drug which was doing mortality benefit in late disease, especially if you are seronegative. That means antibody to nucleocapsid and antibody to spike are negative. So we used monoclonal antibody cocktail liberally in the last 6 months for OPD patients, for hospitalized patients. For OPD patients, irrespective of their antibody status, for hospitalized patients who are severely ill, only in those who were seronegative, and found a great response, great reduction in progression to severe disease and death. But what happens with Omicron is the big dampener. Casivrimab, imdevimab against Omicron, it just doesn't work. So I told you, Casivrimab, imdevimab acts against the receptor binding domain of spike protein, and that is where 29 mutations have happened in this Omicron variant, because of which it can dodge these monoclonal antibodies. These monoclonal antibodies can't recognize the receptor binding domain, because of which it does not kill the Omicron variant. You can see here for Delta variant, almost 100% inhibition was there. For Omicron, 0% inhibition. So our age-old friends, Casivrimab, imdevimab cocktail, sadly are out, at least for the Omicron pandemic. Maybe during the next pandemic with the new variant, maybe it will work. But for this variant, it is out. It cannot work. So they looked at many monoclonal antibodies and looked at whether it can be used. You can see none of the monoclonal antibodies which were tested, other than only one, sotrovimab, is what works against Omicron. And that is my next question. What is sotrovimab? Again, sotrovimab is a monoclonal antibody, just like Casivrimab, imdevimab cocktail. It is not available in India, but it will be available in India very soon. In the next month, maybe sotrovimab will be available in India as well. And there are trials now about use of sotrovimab in elderly patients and people with comorbidities. What is different? How come sotrovimab can neutralize Omicron while Casivrimab, imdevimab can't neutralize Omicron? Because the target of this is an epitope which lies outside the receptor binding domain. Remember, the most mutable region of the spike protein is the receptor binding domain. So if you have any antibody which works against the receptor binding domain, the mutations will cause problems. But if you have this antibody like sotrovimab binding at a region other than the receptor binding domain, then it is not that mutable, because of which it can bind to any variant, whether it is alpha, beta, delta, Omicron, and can destroy it. So this is why it is a conserved epitope. It can neutralize SARS-CoV-2 irrespective of variant. As of now, this monoclonal antibody looks like a variant-proof monoclonal antibody. And this trial has clearly shown that if you give sotrovimab, reduction of progression to severe disease and death can again be almost 85%. So as I said, all 5 agents which I have talked about, Paxlovid, 90% reduction if used within the first 5 days, Molnupiravir, 50% reduction to severe disease and death if used within first 5 days, early Remdesivir, 87% reduction to severe disease and death if used within the first 7 days, monoclonal cocktail, sadly out, sotrovimab used within the first 7 days, 87% reduction of risk of progression to severe disease and death. So find the right population, find the right patient, give him antiviral, any of them which I have told, your risk of progression to severe disease will be much lower, your death rate will be much lower. Secondly, remember, we have only 75% people in India who are fully vaccinated, only 1% who are boosted. So you can see how many people, almost 25% population is unvaccinated or partially vaccinated, and almost majority of us are losing our immunity to Omicron very fast. So in such a population, if you have comorbidities, if you are elderly population, using these antivirals can really do a much greater job than what I have told. So that's why we then published our own hospital guidelines, the Noble Hospital Guidelines, where we have made it very clear that if a mild patient comes to you within the first 5 to 7 days of illness, he's above 60 years of age, or he is young and he has comorbidities like diabetes or any other associated comorbidity, or he's just plain unvaccinated or partially vaccinated. That means he has no comorbidity, but he just comes and tells you, "Sir, vaccine is negative." Here is 3 categories of patients who have a very high risk of progression to severe disease. There, the drug of choice will be early onset remdesivir, especially because we don't have sotrovimab, we don't have Paxlovid. Once Paxlovid comes, remdesivir will be replaced by Paxlovid or by sotrovimab. So you can give remdesivir during that time. Symptomatic treatment like montelukast or levocetirizine can be given for sore throat. But remember, other drugs like doxycycline, ivermectin, favipiravir, azithromycin, vitamin B, vitamin C, vitamin D, steroids, complete zinc, completely no. These are not antivirals, should not be prescribed to any of our patients on OPD basis. If the person is not willing for admission, he says, "No, I cannot get admitted for 3 days. I'm not going to come for daycare admission." Then molnupiravir is an effective antiviral, alternate antiviral, but you need to tell diabetics or people with prior COVID infection that the data is not very clear, it might not work, and also have to look at whether the female wants to get pregnant or no. In that case, you cannot use molnupiravir. Rest of the guidelines remain the same. What about young people? So if young people are there who have no comorbidities, they are fully vaccinated, then you don't need to do anything other than symptomatic treatment, just montelukast, levocetirizine, paracetamol. Again, no doxycycline, no ivermectin, no favipiravir, no azithromycin, no vitamin B, no vitamin D, no zinc. This is another take-home message. If you want to use antivirals in the first 5 to 7 days, there are only 2 choices for you, remdesivir or molnupiravir. If the person has no comorbidities, just symptomatic treatment. But if he still gets fever, if he still has body ache, then you can consider this in that population as well. Other than that, nothing has to be used. Once Paxlovid and sotrovimab comes, we will update the guidelines as to where it can be used. So what are the list of comorbidities? There is a long list of comorbidities which have to be asked in patients because many times patients won't tell you. So right from cancers to cerebrovascular disease, chronic kidney disease, chronic lung disease, liver cirrhosis, alcoholic hepatitis, diabetes mellitus, heart conditions, patients undergoing PTCA or CABG, mental health disorders like mood disorders, depression, schizophrenia, obesity with a BMI more than 30, pregnancy, smoking, tuberculosis, children with Down syndrome, children with HIV, neurologic conditions, sickle cell disease, solid organ transplant, substance use disorders, corticosteroids, immunosuppressive medications, thalassemia, asthma, hypertension, all these are risk factors. So remember, you have to ask for comorbidities. Many times people won't tell you. Obesity is a silent pandemic in India, and people are very routinely above 30 kilogram per meter square. They're at high risk. So many people ask me, "Sir, I have no diabetes, I have no hypertension. How come I landed up in pneumonia?" I always tell them, have a look at your weight and have a look at your BMI. Your BMI must be about 30, because of which you landed up in severe disease. So obesity is a disease. It has a higher risk of progression to severe disease. Look at comorbidities, otherwise you will not understand which patient to give antiviral. Give antivirals only to those who are elderly or who have significant comorbidities. No need to treat with antivirals for patients who are young without comorbidities. And that is what we want to see. We are now planning already started this study, which is known as the API COVID-22 study. And these are multiple authors on this. Many of them have lectured you in the past. We are going to look at the safety, efficacy, and tolerability of all antiviral drugs in Pune, prescribed for patients with mild COVID-19, to look at what is the difference between giving these drugs versus placebo for progression to severe disease. All these hospitals have agreed to enter into the trial, and hopefully we can enroll thousands of patients during the Omicron variant to see whether what antivirals we are giving, like remdesivir, molnupiravir, or sometimes even just symptomatic treatment, whether it is preventing progression to severe disease or no. So in conclusion, the second COVID wave saw many younger patients with lesser comorbidities getting admitted. The third COVID wave will be fueled by Omicron variant, which has increased transmission, increased infectivity, but lower hospitalization and lower mortality. Monoclonal antibody cocktail as antiviral, which is sotrovimab, will become number 1. Tocilizumab will continue to be used for patients who are in cytokine storm. Molnupiravir and Paxlovid are oral antivirals, and it gives me immense pleasure that once these will be available, majority of the COVID patients can be tackled on OPD basis, won't require hospitalization, and hopefully our hospital admissions and ICU admissions will come down even further. Time has come now to stop using casivimab, imdevimab, monoclonal antibody cocktail due to emergence of Omicron variant. It should not be prescribed anymore. Similarly, steroids should not be prescribed to any patient on OPD basis. Only antivirals if needed. Otherwise, just symptomatic treatment with montelukast or levocetirizine and paracetamol. COVID-19 vaccines are indeed a terrific scientific breakthrough. They work against all variants, and it is our responsibility to fully vaccinate 100% of people in Pune and start and encourage all elderly, all healthcare workers, all frontline workers, and all people with comorbidities to take their booster shots. Hopefully, in the second half of 2022, we won't be meeting online. We will be meeting offline in the IMA headquarters in Pune. Thank you. And I'll take any questions which come my way.
Amit, that was a fantastic lecture covering almost all the concerning aspects with regards to treatment of COVID. And we see appreciation in the chat box that everybody has appreciated the antiviral rational use.
Thank you.
A few questions.
Yeah.
Government has reduced the home isolation period to 7 days from 14 days. How long COVID is infectious?
So that is a very good question. Remember that Omicron is as infectious as Delta, if not more. So ideally, the same guidelines that all patients who are Omicron positive should remain in home isolation for 10 days. But remember that if everybody remains in home isolation for 10 days, 70% of our healthcare staff is today sick, either having fever, cough, and they are positive. So if 70% of our staff remain in home isolation for 10 days, we won't have any nurses, any doctors, any class 3, class 4 workers to work. So the 7 days is just a kaam chalao jugad approach, which has been taken by multiple governments all over the world, where they say that on day 6 and 7 of your home isolation, you do a rapid antigen test. If your rapid antigen test is negative, that means you are not infectious to others, then you can join back to work. So the 7 days of home quarantine comes with a rider that you have to have 2 rapid antigen tests which have to be negative. You just can't join back directly on 7 days without doing a rapid antigen test, because if you join back without doing a rapid antigen test, you remain infectious to other people whom you work with. So 7 days, yes, in home isolation for Omicron. On day 6 and day 7, do a rapid antigen test. If 2 rapid antigen tests are negative, join back to work immediately, irrespective of where you are working, whether you are working in a hospital or you are working in a company, no problem. If you still test positive on day 7, stay till day 10, do a rapid antigen test on day 10. If it is negative, then join back on day 11. That is what the guidelines should actually say. But because everybody is so scared of writing about rapid antigen test, they have just said, stay for 7 days and come back to work.
One more question that I had, since you're mentioning that vaccine is not of much help for Omicron, then why are we insisting on booster doses?
See, the main thing is, it is a misconception that vaccine doesn't work against Omicron. There are 4 things which a vaccine should prevent. Vaccine should prevent infection, vaccine should prevent symptomatic disease, vaccine should prevent hospitalization, vaccine should prevent death. Once you give a booster, so I'll just come to the point. Once you are fully vaccinated, then these 4 things are prevented for the Delta variant. For the Omicron variant, whether it prevents infection, that data is still insufficient. But a fully vaccinated person for up to 6 months after the second dose does have protection against symptomatic disease, does have protection against hospitalization, almost 70%, and does have protection from death, almost 60 to 70%. What we are doing by giving a booster is that after 6 months, the protection against hospitalization and the protection against death starts waning. So by giving a booster, we are again jacking it up to 90% protection from symptomatic disease, almost 75 to 80% protection from hospitalization, and almost 75 to 80% protection from death. So this is a misconception that vaccines and boosters don't work against Omicron. Vaccines and boosters do work against symptomatic disease, hospitalization, and death of Omicron. Whether they can prevent infection, that data is still not available. But what we are more interested is, patient should not get symptomatic disease, patient should not get hospitalized, and patient should not die. For that, vaccines are doing an excellent job, almost 97% reduction. So if you look at the US data, if you are fully vaccinated and boosted, then your risk of protection from Omicron or Delta or any severe disease is almost 500 times better as compared to an unvaccinated person. So the question is boost, boost, boost. That is really needed.
Amit, one last question that everybody, common person is asking is, since you are an infectious disease specialist, can you look at the sorcerer's stone and give us some hint as to, in your circles, what is going to be the future next 1 year with regards to COVID?
See, this wave will end by Feb end. After that, majority of the restrictions will go. We will return to a normal life. And we will remain that way at least for 4 to 6 months. Within the 4 to 6 months, if we don't boost majority of the Indian population, and if we don't vaccinate majority of Africa, remember 3 billion people in Africa have not even received a single dose of vaccine. Well, the rest of the world has almost reached to boosters. So if you look at Afghanistan, Pakistan, some amount of Middle East and entire Africa, barring Southern Africa, 3 billion people have not even received a single dose. They are culture media for COVID. They are the culture media for the next variant. So if in these 4 to 6 months, we don't get our act together, we don't vaccinate entire Africa, and we don't boost majority of India, within the next 4 to 6 months, there will be another variant, which will be even more dangerous, hopefully not than Delta. So the next 4 to 6 months, once this pandemic goes down, is very, very important. We cannot slacken our guard. We can't say everything is over, let's start enjoying. No, we need to boost, and we not need to vaccinate entire Africa. And I think India is at the forefront with Serum Institute exporting almost 1 billion doses to Africa. Hopefully that will happen, and that will be the end. Once we vaccinate everyone, the epidemic will end or it will become endemic. But unless we vaccinate everybody, everybody is at risk. So the West is not understanding, by not vaccinating Africa is actually creating a culture medium for the next pandemic to rise. And I fear that is what will happen.
Amit, excellent deliberation on this complicated topic. And from IMA Pune, we appreciate your efforts for joining us. And thank you very much for this excellent lecture. I request Dr. B.L. Deshmukh sir, our president, to felicitate you with a bouquet, and Dr. sir to felicitate with a...
This is bouquet for you.
Thank you, sir.
Sir, thank you very much, sir.
Thank you, thank you, sir.
Thank you, sir.
We also thank Dr. Rajan Sanchiti sir, who is our MMC observer today for this webinar on COVID-19. And from IMA Pune, we felicitate sir as well. Thank you, sir. Amit, since there are no more questions in the chat box, I request Dr. Sunil Ingre sir to conclude today's webinar.
Hello, friends. We should be thankful to all the teachers that all the 4 teachers who have really been Corona warriors. They have always kept themselves updated with the world, and they have always tried to give us the correct guidelines during all this COVID era. And I thank you. I thank all the speakers, as well as I thank all the participants for participating in this webinar. And I declare that this webinar is over. Thank you very much. End करो?